I am Dr. William Powers. I am the sole practitioner at the Powers Family Medicine Center, which is this huge office of 3 exam rooms in Farmington Hills. I have a very unique doctor in that I treat transgender patients, and I never set out to do this. I had one patient with congenital adrenal hyperplasia, and after I diagnosed him with that, they told me that their sibling, basically that, my sister says she's my brother now, can you help him? And I said, yeah. So they came in and I met them, and I basically said, sure, I'd love to provide this care for you. And this was down in Monroe County. And there was nobody down there that would do transgender care, like no one, and they just didn't have access to it. So I said, sure, this is something that I will do. Let me talk to my attending first. And I had a super cool attending, Jessica Sharon, who basically said, if you get certified in WPATH method, you can do it. I said, okay. So me and the patient went to the classes, I learned how to do it, and then I had 1. Then I had 2, then I had 4. And then by the time I graduated from residency, I had 50. I was nominated for Resident of the Year for my clinic. It was pretty cool. But afterwards, I couldn't find a job because a lot of people didn't want to hire somebody that took care of transgender people. It just wasn't the thing that they wanted in their clinics. And I know this because me and my wife, who's sitting right there, would apply to the same thing. And we were both chief at our program, both had excellent board scores, and she would get a call back and I wouldn't. So I realized pretty quickly that something was amiss, and a couple places were honest enough to say, yeah, we don't want those people here. So fast forward a few years later, and I now open my own clinic. I have about 1,500 transgender people that I've seen over the past few years, and I have developed a new way of doing hormonal transitioning that is different from the WPATH method. It requires less drugs and it's safer, and we're going to talk about it. But first, what I want you guys to basically take from this, understanding gender dysphoria in the transgender patient, preventative medicine for transgender people, and understanding the process of basic hormonal transitioning. At the end of this lecture, you should know how to transition someone. It's not that hard. If you can handle treating diabetes, you can handle this. Diabetes is vastly harder than this. Lectures designed to be presented to physicians, so there are people in the audience that I recognize that are not physicians. Understand it's not meant for you, but you can still be here. It's totally welcome to. But some of the language is very medical in nature, and not all of it is super PC. Also, no major medical society has any transgender guidelines. No AMA, no ACOG, no nothing. The 2 main sets of guidelines are the UCSF and the WPATH, which is the World Professional Association for Transgender Health. They have not changed a whole lot. UCSF is probably the better of the 2. WPATH has been more or less the same for like the past 40 years. I haven't really updated it a whole lot. And then mine, which are not officially published yet, but will be, and I'm working on it. So anyways, because I have so many patients, I derive information different than a normal practice. About 75% of my patients now are transgender, which is pretty wild. So I see things that other people don't, because when you have that much and you're a doctor, and doctors are good at pattern recognition, you spot patterns and you start to see things that are interesting. Like last week, I had 4 patients with a tertiary nipple, all transgender. I don't see that often, but then all of a sudden in a row, they all were a thing. I don't know if it was just like statistical anomaly or what, but now I'm looking for 3rd nipples on trans patients. And it makes sense. Mammalian duct abnormalities and other things would be associated with gender dysphoria, which we're going to talk about. There's been a couple people over the years that are not doctors that have helped me with this. I didn't get all this knowledge because I'm such a genius. I got a lot of it because transgender women and transgender men are experimenting on themselves in the street with DIY hormones. And some of them are biochemists. And some of them are very smart people who figured some stuff out, shared it with me, and I listened and tried it, and it worked better than what everybody else did. So I credit them here. How do they view me? So I walk into a room and I see a patient, and it's a young transgender man. He's, say, 18 to 25 years old. And I say, hey, I'm Dr. Powers. Nice to meet you. What can I do for you? Testosterone. Like, what? Testosterone. I'm here for testosterone. I'm like, well, I'm sorry. Why do you want testosterone? Like, there's just no, they're there for a purpose. And you'll understand by the end of the lecture why this is and why transgender people react this way towards medical providers. But basically, they view me as a gatekeeping doctor robot. I am the guy who gives them testosterone. I am the thing they have to get past in order to get it. This is literally how they view us, and this is not what we are. I am very much not a normal professional doctor. I have a lot of really interesting hobbies. I was just talking about how I heat my house with Bitcoin mining, big computer nerd. I used to have 2 Guinness World Record cats. One was the tallest cat to ever live, and the other one had the longest tail ever on a cat. I'm really good at manipulating the biology of living things, and I designed a diet for them that I thought would be biochemically ideal for feline species. It seems like I was right. I play a lot of Pokemon Go, and I'm into steampunk. I do cosplay. I'll be going this weekend to Detroit Comic-Con, probably dressed like that. So that's Electric Forest. Me and my wife went to Tomorrowland this year in Belgium, so we do a lot of fun stuff. So why didn't everybody do this? Well, it's scary. People are afraid of doing it. There's a lot of personal beliefs that people have. I don't agree with that. Okay. There is no major medical association that says this is how you're supposed to do it. So when you are in court being sued for what you did, what do you point to and say this is the standard of care? There is none. It's all off-label. None of these drugs are approved to treat transgender people for gender anything. Completely all off-label. And we live in a litigious society, so everybody's afraid of that. Why do I do it? Ethics, autonomy. Basically, if you can go to some other doctor who will split your tongue in half and make you look like the lizard man, and you can make that decision as an informed adult, I think this is a lot less than that, and we let people do with body modification. But really the main reason and why I started doing it was suicidality. 41% of transgender people will attempt suicide by age 30. Just let that, that's an enormous number. 41% of them will try and kill themselves. They commit suicide at a rate higher than every other medical condition there is combined. Cancer, HIV, all of those diagnoses that are horrible, chronic pain, they still don't kill themselves anywhere near as much as gender dysphoria. So why do people have it? It is not a mental illness. It is effectively the modification of the neural architecture due to something. And here are some of the somethings. DES is diethylstilbestrol. It is a drug that was used basically back in the 30s to 70s in the US, elsewhere in the world more. It's 600 times stronger than estrogen. It's a super potent estrogen. And if you give it to somebody, you do so because they had a miscarriage. And it was a wonder drug called Desplex, and we handed it out like candy because if a woman had a miscarriage, you gave them this, the next one carried to term. What do you think happens when you expose a male fetus to a super estrogen throughout the entire pregnancy? I don't know. We do. It's this. Congenital adrenal hyperplasia is a virilization disorder related to 17-beta hydroxylase, 21-hydroxylase deficiencies. Aromatase excess or deficiency is when the aromatase enzyme, which copies basically blue hormones, androstenedione, testosterone, over to estrone, estradiol, that being either too strong or not strong enough can screw things up. Klinefelter's and intersex syndrome, XXY. Technically, all of these are under the intersex umbrella, which are disorders of sexual development, which is what we now call them, the DSDs. So intersex, even as a word, we're not really using as much because where do we draw the line as what is intersex? How far do you have to go to be considered intersex? We don't really have a description for that. De La Chapelle's super cool. You're XX, but due to a freak thing that occurs at conception, the SRY gene from a Y chromosome gets copied over to you. And so despite being XX, you have a penis and testicles and look like me. But they're XX, and they're infertile. PCOS, everybody knows PCOS. Androgen insensitivity syndrome. So this is in the media right now because of a runner called Caster Semenya. She has partial androgen insensitivity syndrome. So Caster has a vagina and breasts and looks like a very masculine woman. She's XY. This condition, if you have it, and I've seen this personally once. I had a 17-year-old girl who came to me completely unrelated to my transgender clinic, was the daughter of one of my other patients who'd never had a period. She just didn't have one. And that was weird. So they sent me in and I was, all right, well, let's check you out. And I went to do the pap and she had no cervix. And I was like, okay, so this is either Müllerian agenesis or this. And when I karyotyped her, she was XY. It was not a fun diagnosis to give a young girl like that. What's really interesting is they're actually generally very attractive and ultra feminine. They're like the most feminine human you could possibly imagine because they have no functional testosterone ability whatsoever. No body hair, nothing. Prenatal exposure to estrogen, androgens, obviously. Psychological disorders, there is a strong association between autism spectrum and Asperger's and gender dysphoria. The CAG repeat sequence variance is pretty cool. So on the end of the testosterone receptor, just like how when you think about trinucleotide repeat sequence diseases, the testosterone receptor is like AGTQ, AB, AG, 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 doing its thing. And then when you reach the end of the code for it, it goes CAG, 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 CAG a certain number of times. The more number of times, the more resistant it is, the binding ligand energy, the Ka changes to hold off testosterone. The shorter it is, the more sensitive. I have seen people who have completely normal labs. I have a patient that has completely normal androgen labs, assigned female at birth and has a full beard. Completely normal. This is the only explanation I can have for it, is the receptor is ultra sensitive to the effects of testosterone. And of course, neuroanatomical structural variants. I include abuse history in here because it was formerly the cause of why people are transgender. They must have been abused as a kid. I have one patient, one in 1,500 that reports this. They identify as non-binary. They were physically, sexually, and emotionally abused as a kid. And to them, the idea of identifying as female is vulnerable and weak. And so they use they, them pronouns, and they don't identify as male, they don't identify as female, they just identify as what we call an NB, or a non-binary person. Slang is ENBY, NB, if you see that written down. But basically I included it in because it's a thing. I have seen it. Like I have seen one case of what's called autogynephilia, which is where a patient sexualizes the idea of themselves as a woman, a male patient does, and then wants to transition for the sexual gratification aspect of it. I have seen it once in 6 years. So it is definitely not a common thing, but they do happen. Okay. So the overwhelming majority of women that have this disease, congenital adrenal hyperplasia, are same-sex attracted, like 99% of them. And the severity, so to speak, of their same-sex attraction is correlated with the degree of virilization. So the more severe the disease, the gayer they are. That's a known phenomenon with them. This has been documented to death. But basically, if you have this and you're a woman, you're attracted to women, or maybe you're 1% that isn't as Catholic or something, I don't know. But the short and narrow here is that 5.2% of women with CAH identify as male. Statistically, 0.3% of women identify as male. Obviously, this is doing a thing. We can clearly see that that is a thing. It's blatantly obvious. There's a direct correlate. Prenatal exposure to DES, which we already talked about, it was first noted in 1954, known as male pseudohermaphrodism. They're seeing undescended testicles, hypospadias, and testicular feminization syndrome in boys. Then, of course, we started seeing archives of general psychiatry and other people doing about it, and then no one really cared because, you know, being gay at that time was not something people talked about. But when, you know, all the women started, the daughters of DES started getting vaginal clear cell adenocarcinoma, then all of a sudden they pulled it. But the reason I bring the DES up is I have a very interesting situation. So I have two patients that I just coincidentally had. They're both from the same area. They each decided to transition. So they came to me for the purposes of hormonal transitioning. They got a 23andMe done and discovered they had a sibling that they didn't know about. And they were like, oh my God. So they contacted each other and reached out. And the irony of this is that each of them was afraid to tell the other one, because they were, you know, brothers, that they had transitioned. They were so afraid that they had just gotten this sibling and that the sibling would be intolerant to the fact they were transgender, and then that would be it. Like that they finally found this person and then they wouldn't be there. The hilarity is that when one finally came out to the other one before they were going to meet, they're like, hey, just so you know, when I show up, I'm going to be wearing a dress. Because what they had seen for photographs prior to that was prior to them transitioning. The other person didn't reply. They didn't reply for like 24 hours, and my first patient was freaking out. And then finally when they replied, they were like, I didn't know how to respond to this, but I'm also transgender. So they went and they looked up some of their medical history, and they had found out mom had had multiple miscarriages beforehand. It was in the right time period for DES. One of the patients has hypospadias. It was like a whole thing. So it's really fascinating. It's just sheer coincidence down in Monroe. I had these two people who, one was given up for adoption and the other one was kept. That's how this panned out. Kind of wild. This is pretty much the most conclusive thing that I can use to point to bigotry and be like, you're wrong. When people are like, these people are mentally ill. I'm like, yep, here you go. No, they're not. They're not. Their brains are literally wired structurally to look like their preferred gender before the taking of any hormones whatsoever. So if I take a 18-year-old female who says, I identify as male, transgender man, and I scan his head in an MRI machine, the MRI machine will spit back to me, this is a male brain. We can actually do that. And we've been able to do this over and over again, starting at 2009 up to 2015 is the most recent time the study's been done. It's been repeated 4 times, same findings every single time. We structurally can see gender identity on neuroanatomy and neural architecture now. So, as I have said, this is definitely not a thing. And people are always like, these people are mentally ill, we should be treating them, you know, with therapy and helping them out. We can't do that. We've tried. Extensively attempted to use counseling and SSRIs and everything else to make these people feel better and you know, congruent with their gender, but it would be no different than basically telling someone who has red hair that we don't accept your red hair and you have to dye it, which is basically what they do in society until they come out. There's nothing they can do about it. They're stuck this way. Their neural architecture is wired this way. So the best that we can do for them in medicine is to at least make their external appearance congruent with how they feel about themselves. Secondary to that, taking the hormones actually gives them the sense of wellness that does not seem to come with the hormones they're other previously assigned. So it's really strange, is not only just does giving them estrogen give them or testosterone in the body that they want, when they're on that hormone, depression and other psychiatric things go away. The patient feels more well, which is really neat because whenever I meet a new trans patient and they come in with severe depression and they want to transition, I never start an SSRI before I start hormones because the overwhelming majority of them don't need it. Once they start hormones, the depression issue goes away. So I was under the impression for a while that there was this concept that the overwhelming majority of transgender people, if offered the opportunity to take a pill, go to bed, and wake up in the morning cis. Cis being is what you are if your gender identity, how you view yourself in your head, is the same as what you see when you look down, you are cisgender. Transgender, like think about chemistry, I mean cis and trans is opposite side, they've switched. With these people, I had always thought that they would respond accordingly to this, and they would say, yep, this is how I feel, and I would gladly take the pill and be cis right away. So I thought that, and I had this in my old lecture, and I recently updated it because it's not true. Actually, I polled my patients, and I got about, I think, 300 and something people, and what I effectively got was, where is it here? This is the replies that I got from people. Where am I looking at? There you go. So yeah, over 300 respondents, 30% of people said they would take the pill. The rest spoke really against it. Some people were very even offended that I had even talked about the possibility of such a pill and how it was threatening to their identity. And this is what they said, basically. I would never accept a pill that would make me happy with my assigned at birth gender. This would effectively be personality death. The person who existed after taking that pill would no longer be me. I'm a woman, and that's very important to who I am and how my experiences have been shaped. Now, if you offered me a magic, perfect, immediate transition button, I'd press that in a heartbeat. But the idea is this person viewed their identity, their gender identity, as core to who they were as a human being. Kind of like if you were to think about doing a lobotomy on someone, you would take out a piece of who they are. Those neurons, those memories comprise effectively the essence of what that person is. So to remove that would remove that aspect of their person. Now, what was very fascinating about this is some of the things that people said here. Having contemplated that myself, I can appreciate their desperation. If there was a way to live happily without all the pain and loss, I would have done it in a heartbeat. For me, the magic pill was transition, but it was a very bitter pill to swallow. Even knowing how hard it is and what they had to go through to do this, the social ostracization, the loss of family, jobs, like literally everything, they still would do it. And what was really fascinating is people early in transition, before starting, were like, give me the pill. But people who had already transitioned, who'd gone through the personality growth and changes as a human being, were like, no, 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 I'm not doing that. This is who I am. And that was pretty neat to see that actually stratified out. So what about the surgery? Does the surgery actually work? Well, here you go. We'll start with first just hormones. So these are people talking about just hormones here, and even though they had undergone gender-affirming surgery, these are the general population responses. Approximately 4 out of 5 people report significant improvements across the board. That they are better life, better quality of life, sexual function, happiness, depression, all those things improved. When we look at surgery, the regret rate for surgery, this is the best study ever done. I'm on Reddit a lot, and there's a subreddit called The Donald, and it's obviously, Donald Trump subreddit. And they constantly post this one study, this very small study that was done that talks about how all these people regretted having gender-affirming surgery. Yeah, it's a terrible study. This study was done over a 50-year time frame on 767 people who underwent gender-affirming surgery. Of them, 2.2% regretted having it done. LASIK, like getting your eyes corrected, has a 5% regret rate. So these people literally had their genitals reconstructed, and 2.2% of them were like, meh, I wouldn't do it again. That's the regret rate here. So this is legitimately how many of these people said that they benefited from having it done. That is probably below even the complication rate. I'd imagine way more than that many had complications or problems and it didn't turn out exactly as they wanted, and they were still happier and better off as a result. So how do I do it? How do we actually take somebody from one gender and transfer them to the other one? This is how it's basically done in your body, how you became the gender you are now that you express physically as your phenotype. So you have, and we're going to talk about two, gender identity gender expression, sexual identity. These things are all different, and I'll get into it later. But this is basically how humans make sex hormones. This is what I do all day. I look at these things, I order these labs, and I fix them. How is it done? Nearly everybody has to go through some form of psychiatric evaluation. Most of them have a WPATH letter, which is a letter from a therapist that says this person meets the criteria for gender dysphoria, and I think they'd be a good candidate for HRT. However, some of them do not, and those that do not are usually because they are from a lower socioeconomic class. They have Medicaid, like a Meridian or Molina or crappy insurance, and paying $175 an hour to a therapist for 6 months every week is not something within their price range. So for them, I offer something called informed consent. Informed consent is effectively what you give when you go get a tattoo. You say, I am an adult and I understand the risks and benefits of this. I will not do informed consent on someone who has a major psychiatric history. If you are bipolar with mania, you better not be manic when you come to me to do this. I will make sure you are stable before I will do it. If you have ever had psychosis of any kind, nope. You go to psychiatry for clearance. But if a perfectly educated and consenting, stable adult on no medicines comes to me and says, I want to do this, I go, okay. So I give them this form. And the form has every risk and benefit that can possibly happen. It's like 15 pages long. And they study it, and they learn it, and they go to this place called Transcend the Binary, where basically there are a bunch of doctors and pharmacists, people who volunteer their time to meet with these people and quiz them and make sure they truly understand. And if they do, they write them a letter that says, this patient understands the risks and benefits, and then they come back. And along with their physical examination and lab work, I start them, as we said there. Pretty much what I just talked about in terms of informed consent. All right, so here's where we begin. So female to male. So you have a kid. Any kid comes to you. I don't care whether you are internal medicine or family medicine or it doesn't matter. Kid comes to you and says, I want to transition. And they are pre-pubertal. They are not ready for hormones, so to speak. They wouldn't naturally be making their own. Just give them Lupron. All you do is you press pause on puberty, and it just stops. They stop growing breasts, their penis gets no bigger, their testicles get no bigger, they don't get any facial hair. It's just you keep them in kid stage, pause, and you give them time. The total risk of doing this is if they're on Lupron for many years, their end bone mineral density will not be as high as it would have been had they gone through puberty earlier. But that's about it. That's pretty much the risk. The other risk is they kill themselves, which to me is like, when you're 70, your bone mineral density versus you die at 11. So I block these kids. I say, yep, you're blocked. Your hormones are blocked. Go to gender therapy. And they go. And they go to see psychiatry and gender therapists, and they figure out whether or not this is the right thing for them. For some kids, it is. For some, it's not. They literally will grow out of it. It's a phase they went through for whatever reason, but for the ones that don't, they come back. We start them on HRT when is the age-appropriate time, which is effectively puberty. Lupron is the drug that's used to do this. Every now and again, I have a female-to-male patient who can't use Lupron or they can't get it covered. I'll use anastrozole, which is an aromatase inhibitor, which blocks the conversion of the blues to the pinks. Basically, in order to treat someone for a female-to-male hormonal transitioning, we use testosterone in pretty much any imaginable form. Don't use DHEA because it just gets metabolized into more female hormones. It's a myth that works in that way. It actually makes their problem worse. But a lot of people think that this is a good idea. But in general, I use about 100 milligrams a week injectable. There is oral testosterone in Europe. It's not a thing we really have. We have a small thing called Estratest, which is like a little dose of testosterone for postmenopausal women with low libido. It's not nearly enough to transition with, and it's not something I would recommend because it has increased coagulability problems. But basically, injectable T or transdermal T are how pretty much everybody does, with the exception of some very rare patients who get something called a Testopel, which is a testosterone implant, and you replace them every 4 to 6 months. So you get some rapid changes that occur and some changes that take a little longer. Some of the things that are changed is the increased musculature and decreased body fat, development of facial and body hair, deepening of the voice, male pattern baldness, which happens way more often than people wish it did, but it's the trade-off you make. Enlargement of the clitoris is like almost immediate. Like we're talking within weeks, it'll start to grow. Growth spurt and closure of growth plates. So the interesting part about this is that when it comes to treating trans women and trans men that are kids, I tend to let the trans men kids, like female to male, go longer on Lupron. And the reason for this is that they grow taller. So testosterone and estrogen close epiphyseal growth plates. So if you hold them open longer by not giving them the hormones earlier, they grow taller and they fit into society better, which is very much a heightist, sort of thing. But regardless, if the end goal is for them to pass, I try and get them as tall as I can. So this is kind of effectively, if you think about it, why you see a lot of transgender women. This is my theory, total theory, but that you see transgender women who are very tall, like inordinately tall, like 6'6", and they tend to stand out, and you're like, wow, those trans women are tall. Like collectively, my transgender women are probably like 5'10". Like they are taller than average would be for the average American man. And I think this is because of resistance to testosterone due to whatever other genetic mutations they have, and they have a ton of them that I could go through, results in longer growth plates. My trans men, it's the opposite. They tend to be shorter, much, much shorter, usually between 5 foot and 5'3". And that's just the way it works out. So I believe that this is the reason why it's linked. One of the coolest things you can do, if you really want to be Dr. Off-label like me, is you can use minoxidil, which is Rogaine, on the face. Do not do this until the patient has peach fuzz. And by peach fuzz, I mean like, you ever been driving along in the car and the sun is setting and you look over to your left at your mom or whatever female person you have in your life and you're like, oh my God, their face is so hairy. Right? We've all experienced that. It's the light refracting through the light on their face, their vellus hair, okay? Some people have more vellus hair than others, but if you have a lot of vellus hair to begin with, when you start using tea, it starts to thicken to become that sort of peach fuzz that then becomes facial hair. Minoxidil causes the transformation of vellus hair into terminal hair. Subsequently, you can use it on the face, but don't do this until effectively you have gotten fuzzies or you are wasting their time, and getting somebody to be compliant with a thing that they rub onto their face once or twice a day is difficult, especially when they don't see any results. When the results that they do see is all of the hair that they've grown so far falling out, if you do not warn them about it, they will stop using the drug. Ironically, this is the stage when it's the most important, because why it's falling out is the transformation from vellus to terminal, and that middle velo-terminal stage causes a shedding event. The hair cells basically die off, drop the shed, they lose the hair, and then they start again with a new, stronger terminal follicle that makes you can hear the scritchies. That's it. That's terminal hair. That's what you're trying to make. This drug will do that. I can get a beard on somebody in under a year, which is pretty wild, where otherwise it takes years to build that. And you think about pubertal boys, they get the dirt stash and blah, blah. Like my patients are like year and a half out, and they have a full beard. All right, so I do something unusual. There are two types of genital surgery for trans men. One is called a phalloplasty, where we create a neopenis, and the other is a metoidoplasty. It used to be you can basically have your penis or feel it too. That is no longer the case. There are some new surgeries that actually give you a sensory phallus. But for the longest time, that was basically your options. We basically sever the clitoris, pull it out, and then more or less attach it there, and it becomes sort of a small penis. And then there's testicular implants that can be placed into the labia, and there's a vaginectomy. The vagina canal is closed, and this is what you get. I'm able to achieve considerably greater growth than other doctors because I dreamed up this idea of using incredibly concentrated testosterone directly to the clitoris. So they literally use 15%, which is about 10 times stronger than androgel, and they put it directly on the clitoris every day, and it grows. And they are beating my door down to get it, because people are coming and be like, I heard you got this cream. And like, it's just spreading throughout the community. It's a thing that I've dreamed up, but nobody's done it before. It actually is very interesting. I don't have a slide in here yet, but I should, about the fact that I actually use a compounded weak testosterone, a 0.5% or weaker, on the penises of transgender women. A lot of times the corpora, the internal structure, doesn't get any smaller. That stays the same, but the skin atrophies. So you end up with like an overwrapped kielbasa. So when they get an erection, it is extremely painful, and the skin can split, just like kind of a postmenopausal woman's vagina. So what I do for them is I give them this low-dose topical tea applied to the penis, which regenerates the tissue, softens it, and gives it its elasticity back. The other reason is that I do it is on my male-to-female kids who were blocked. They don't really grow much of a penis because they don't have the testosterone to make it grow. So there's a very famous transgender girl named Jazz Jennings who went through her whole surgery thing and outline, and the biggest complication she had was her vagina was about this deep. And it was because Jazz had never been allowed to go through regular puberty, which means that she had more or less been a toddler penis. It never grew any, and that's what they were able to use to make the tissue to do the neovagina. So as funny as it is to say, about 6 months before any of my patients go for gender-affirming surgery, I start slathering them up with 0.5% testosterone every day. This will make the biggest, strongest penis possible to go into battle that you're going to use to turn into a neovagina. This is very important to do this because they've often spent 4, 5, 10 years on blockers and have experienced significant genital atrophy as a result. The same can also happen in reverse to transgender men, but not as often. Testosterone seems to be a little friendlier to the vagina, whereas estrogen is a thing that just does not work on trans women's penises. Like, don't even bother, estrace will not work to help them with this issue. Same idea with male to female. Lupron is used to do the blockade. There is a tremendous discussion and argument over what is the best way of doing hormones. It's mine, I assure you. But it's not really a thing that has been settled on anybody yet. So I'll present to you mine and the other options, and you guys can decide for yourselves. Male to female, I mean, you get feminization, breast development, adipose redistribution, testicular atrophy, possible infertility. So infertility is a thing that people talk about a lot, and I actually have not experienced it that much with my patients. So when I have a transgender woman who decides that they want to father children and they still have not had an orchiectomy and they would like to produce sperm, I stop their blockers, I stop their estrogen, I stop everything, and I put them on a drug called Clomid. Clomid is also used for fertility purposes in women, clomiphene, but it increases the LH and FSH secretion from the pituitary, which thereby kind of restores the testicles. And they can go from these atrophied little wimpy, squishy grapes to being like solid, hard, large marbles within the span of about 2 to 3 months. Then they can give themselves a sperm donor, or they can do whatever they need to do to drop their sample or impregnate their partner. And then go right back to how they were before. And I have done this a bunch. So I've actually not had a patient that was infertile that I couldn't fix, except for the ones that had an orchiectomy. And there's nothing I can do about that. Once you've had that, that's pretty much the end of the game. Anyways, so same sort of things in reverse. This is an interesting slide. So when I start people out, I start them between 6 and 10 milligrams a day, spread over the course of the day. Ideally, I would love to have them dose it 5 times a day, but few people are that compliant, so I usually am happy with 3, like 4 milligrams in the morning, 2 in the afternoon, 4 at night. Almost every other doctor will tell you, take all your pills at once, it doesn't matter. That's wrong, and here's why. When you spread the dose over the course of the day, they don't crash. These people who are dosing 10 milligrams of estrogen first thing in the morning, 12 hours later, they've half-lifed out 3 times. They feel like shit. And they always wonder, I'm so tired in the evening. Well, yeah, because you have hormones only part of the day. And that is absolutely not how an ovary works. It's not like an ovary wakes up at 8 a.m. and like has its morning coffee, squirts out some estrogen, and then goes to sleep for the remainder of the day. It doesn't work like that. So why would we do this to humans? I don't know, but I don't. What I discovered that's a really large portion of my treatment is this thing called estrone and estradiole's ratio. Estrone is a metabolite of estradiol, and it's also a thing that's produced from androstenedione. It is about 4% as strong as regular estrogen, regular estradiol, should I say, and it is a competitive agonist for the binding site. I have found some transgender women have a mutation where their body will take estradiol and convert it into estrone. Lots of it, to the point where it's 20, 30 times greater amount of estrone than estradiol. I think this may be actually related to the development of their gender dysphoria, and we're going to talk about it. Now, earlier you saw this slide. And on that slide, this arrow went like this, just down. That is wrong. And it has historically been taught that way, and it is wrong. And specifically, the reason it's wrong is there's 2 enzymes there, 17-beta oxidoreductase and hydroxylase, which are involved in the processing of those 2 hormones. It goes in reverse. It is reversible. And I have found increased or mutations of increased function going one direction or decreased in the other direction, which screws up this ratio. So, what does it matter? Well, let's say that you have a patient, and we're going to just follow the W path standard here really quick, not my methods, we're going to say the W path. So, estradiol, you get it back, it's 100. To me, that's too low, I like it over 300, but W path likes them 100 to 200, so they say that's okay. Great, all right, everything's fine, keep transitioning, have a good day. I get your estrone back, and while your estradiol is 100, this is 500. Most cis women are really around 100, never over 200 ever. Their physiologic range never goes that high. So, what's up with that? Oh, I better lower your estrogen. Yeah, your dose is not enough. Here, you don't have enough estrogen. I need to increase it to get you closer to 200. Oh, nope, you have too much. I have to decrease your dose. Oh, nope, here's your total estrogen. This is pretty much peak ovulatory levels. This is fine. Depending on which lab you ordered and how you looked at this patient, you would come to the wrong conclusion. which is why my whole point is estrone is a key component that you need to measure when you're looking at this. Estrone also is important to measure in any of your women that have had breast cancer or a thrombotic event, because it is implicated in the development of both. So, as we talked about here, the effective estradiol level in this patient is much lower than 100 picograms per milliliter. So let's imagine this. All right, so we got these chairs over here, okay? These are estrogen receptors. So let's say we have 10 guys up here wearing estrogen shirts, and they're like, I'm estradiol, 10 of them. And then I have 50 wearing estrone shirts, and we play musical chairs. What assortment of people are you going to get in there? I mean, obviously, 5 out of 6 chairs are going to be occupied by the people wearing the estrone shirts, because there's way more of it. But they both bind to the receptor. It's just that when the estrone binds, it only gives 4% of the effect. Subsequently, the irony of this is that giving transgender women who have this mutation estradiol creates an enormous amount of estrone in their liver, which then competes with the estradiol for the receptor binding site. So they start transitioning and then stop, because they get the initial feminization burst from estrogens effectively, and then they can never get past that. They just get stuck. And the reason I dreamed this up is I'm like, why are people keep saying this, shots are better, I couldn't transition until I went to shots. I'm like, what would the difference be between oral and shots? Like, I don't get it. And I started looking into the biochemistry of this until I finally dreamed this up with Sigrid, who I quoted at the beginning of the lecture, who I gave credit to. Brilliant woman. But anyways, the relative speed of the enzyme, the 17-beta-hydroxysteroid oxidoreductase and hydroxysteroid dehydrogenase, is interchangeable. So depending on where your mutations are, how many allelic polymorphisms you have in either direction, you're going to either go towards this end of the reaction or the other end. And this is important for transitioning. What's really weird is that I have found elevated estrone levels in transgender women who later went on to have screwed up ratios in this problem before they started transitioning. Meaning their body was taking, when they had non-elevated levels of total estrogen. Their total estrogen is like borderline high or normal, but their estrone is high because they're shunting into this. Now, I think that this is particularly interesting because I have previously been like, estrone's bad, no, terrible estrone. I've been doing that for years once I discovered this. What I recently figured out was that the patients that I started on pills that I switched to shots ended up having better feminization and larger end-stage breasts than the patients I started on shots. And I couldn't figure out why that was. And so I started to think about it, and when we talk about thelarchy, which is the development of breasts before menarche, thelarchy is the development of the breast bud and then its initial formation. That comes from the adrenal glands primarily, from estrone being released in the adrenals. After that happens, eventually there is an inversion when the ovaries kick on, and then you start to progress to Tanner 3, Tanner 4, then you start cycling and you having a period, and then you progress to Tanner 5 and the breasts round out. So I realized, maybe this would be better. So I actually let my patients stay on oral pills even if they have a crappy ratio for 6 to 12 months, then I switch them. Because effectively I'm mimicking thelarchy in a cis girl who would go through the same sort of thing. What's really interesting, and I have yet to totally suss out the mechanism for this, I've had patients that have been on shots for an extremely long time frame, like 3, 4, 5 years, where they are considered done. This is as far as they're going to progress, no more further feminization. And I added an oral dose of 2 milligrams at bedtime, swallowed, not sublingual, not buccal, swallowed, deliberately creating estrone. And all of a sudden they start progressing again. Despite the fact that their estrone level goes up against this ratio. It almost seemed contrary to my theory, but I believe the mechanism for this is that the estrone is actually uptaken into the cell and converted to a different form called E1S, estrone 1-sulfatase, or sulfate. The sulfatase enzyme is the thing that does it. And that form, E1S, hangs out and does nothing. It's sulfated, it just chills. But it can be pulled immediately and then converted to estradiol intracellularly. Now, the serum drifting around estradiol around your body, yeah, that's great that you have that and you have a high level, but it doesn't do anything unless it's inside the cell. This is picked up easier and taken into the cell. So it acts as a reservoir for E1S, and in these patients who've been on shots a really long time, who might have a depleted estrone reservoir, it seems to re-trigger growth in them. So what I do now is when somebody's maxed out, like totally maxed out, I give them this oral dose for a month. And if they start progressing again, they start getting more breast development, I have a phrase that I say all the time, which is sore boob is more boob. If they're sore, they're growing. That's a general marker for it. If they develop tenderness again, then we continue with this. If they don't, I don't do it past a month. All right, so as I talked about, I start them all that way. If the ratio is poor, I switch them to injectable. If the ratio is good, they can be maintained that way. I'd say, even since I would say about half now. I really should update this. I used to say about a third to a quarter, but I'd say about half of them have this genetic issue where they just cannot process it properly. There are the options for transdermal estrogen and implants. I rarely use these, mostly because I can never seem to get as high of a level as I would like, but I have a couple patients who have the mutation with the estrone issue, and they are just terrified of needles. They just won't use them. They're just like, no shots. And I'm like, okay, well, you're stuck how you are, or this. And the option is either transdermal gel or usually 2 to 3 max dose patches simultaneously. There is also estrogen implants, but they're not approved in the US through any sort of like FDA okayed drug, like Testopel is the testosterone one. There isn't an estrogen one. But you can get it compounded at a compounding pharmacy and then do the same thing. It does exist in Europe. So this is what I think is going on here. And this is just a theory, so you can take it with a grain of salt, but I believe that this is actually the cause of why a lot of these people turn out to be transgender women. So if you have this mutation, which I said about half of my patients do, where they crank out this massive estrone level. So when I say that, to be clear, they'll have an estradiol of 100, 150, and I'll measure their estrone. Someone broke the record the other day by having an estradiol of 100 and an estrone of 38.27. Normal estrone is 100 to 200. So that gives you a concept of like how bad the mutation was in them. What they are effectively doing is I'm giving them estrogen. Their liver is like, cool, estrone, pile, and it just starts stacking up more and more and more. Well, if you think about it, what is the other time that a male fetus, besides being a transgender woman, would be exposed to estrogen? Pregnancy. So in pregnancy, you are exposed to mom's estradiol. I eliminated my mom's. I just went, nope, and got rid of it because I don't need it, and my body produced its own androgens, which is why I turned out with my SRY gene expression to be a boy. I am a boy, if you hadn't known. I do also identify as one. But if you have this mutation, you're going to take mom's estrogen and you're going to crank it into estrone. Now, mind you, estrone isn't a super powerful estrogen, but we already know it's enough to at least give people breasts. So if you're exposed to this throughout your entire development period by taking mom's estradiol, converting it to estrone, and building up this reservoir inside your fetal body, what do you think is going to happen to your neural architecture? Well, I don't know. It's not like we don't have a comparative analysis in DES, which shows us exactly what happens when we expose a developing fetus to high levels of estrogens. So this is why I think at least some transgender women who have this mutation are trans because of this mutation. And the sick irony of it is that later in life, when they go to try and actually transition, you put the hormones back in, it makes it harder because their body actually fights them by converting the estradiol I'm using to estrone. So this is an example of a patient just like what I was talking about. I really should use my new patient, the one I just got the crazy labs on the other day, because it's even more pronounced than this one. But basically, this patient had an estradiol of 78 and an estrone of 2100 when I checked it. They were told that this is as far as they could go. They've been on hormones for like 10 years, and that was it. They were kind of happy with how far they had progressed with their transition. But their prior doctor had only been checking the estradiol level. They ranged anywhere from like 80 to 200, and everything was fine. 4 months after I correct their ratio, I saw them as a patient. I'm like, hey, listen, you have this thing. Let me fix this for you. And they were like, very suspicious, because when someone's been doing the same thing for 10 years, it's hard to convince them to change. But they did. They listened to me, and holy crap, did they change. We're talking they went from like a small B to a D by the end of the year. Within 4 months, it was blatantly obvious that I had done something very different with this patient. They were thrilled because they had thought that they had gone as far as they could go. And it was because they had this mutation. I have seen this, which I'm trying to figure out right now. Norvir and cobicistat in my African-American transgender women are 57% HIV positive. I'll repeat that. 57% of my African-American trans women are positive already. That's real. White is about 7 to 12% depending on the state. So in short, a lot of them I have on HIV treatment. I also treat HIV, the thing I do in my clinic. And a lot of the older / middle, and not the brand newest drugs, but the ones from maybe the past 5 years to 10 years ago, use this, cobicistat. It's a booster. It basically inhibits the cytochrome P450 enzyme, keeping the level of the drug higher in the serum. Norvir did the same thing. And they screw with estrogen metabolism. So it also makes this problem even worse. So I would recommend if you have a transgender woman you're fixing this problem on, and they're on one of these drugs, consider one that is an unboosted regimen. I'm not the first person to discover this. It's kind of crazy. This has been known in medical literature for literally almost 15 years. 2005, varied routes of administration affects the way that estrogen metabolism is done. Right here, you can see this was the study. Estrone is a weak estrogen, only 4% of the estrogenic activity of estradiol. I'm not the first guy to dream this up. I already talked about that. However, we've known that it's bad. We know this. Association with estrogen receptor positive breast cancer, relationship between estrogen and estrogen metabolites, the postmenopausal breast cancer risk. This doesn't say here, but I'll tell you that the abstract, the conclusion is estrone's bad, causes cancer. Estrone sulfate promotes human breast cancer cell replication. The effect of estrone on thrombin generation may explain the different thrombotic risk between oral and transdermal hormone replacement therapy. So I only use, in my practice, bioidentical hormones. That's it. If you come in and ask for something else, I say nope. And in 1,500 patients in 5 years, I have had 0 complications. Not a single DVT, pulmonary embolism, nothing. Not even one. And I use doses way higher than what the WPATH says is safe. Statistically, I should have had like 5, but I've had 0. And I think this is the reason, is that I only use bioidenticals and I pay attention to this. Estrone generates thrombin. So if we're giving people oral estradiol and they have this mutation and all of a sudden they have an astronomical amount of thrombin in their blood, what do you expect? All right, let's talk about blockers. So sometimes it's necessary to use blockers. The testosterone sometimes will just go down on its own when you give somebody estrogen or progesterone, but sometimes you really got to beat it. As a result, you use blockers. And the historical way of doing this is stuff like finasteride and spironolactone, which I despise, and I'm going to talk to you about why. But the crux of what I do is to use bioidentical hormones, and on very rare occasion, an androgen receptor inhibitor called bicalutamide to do this job. So I don't prescribe Spiro. If you come to me on Spiro, I will take you off of it. I will not write it. It is the standard of care according to every major medical group everywhere except for me. I'm going to let you know they're going to tell you to write Spiro. Why we think a potassium-sparing diuretic that causes, and this is known, depression, fatigue, visceral adiposity, like it increases serum cortisol levels, which is probably the reason why people get visceral adiposity. We know that it has issues with breast development. So this was a really cool study that took every single transgender woman from like Europe and this whole distribution, like thousands of people. And they looked at what they had used in terms of hormones up to that point. And when they stratified out for different examples and different things, they found that the Spiro group was significantly more likely to seek breast augmentation than every other group. There is a theory that spironolactone causes premature nipple plate fusion, meaning that basically the breasts are not able to achieve the full size they would have otherwise because you have cooked them with Spiro early on in development. So I have also seen this in some patients who took high-dose Spiro, who that almost no matter what I do, and we're talking, I even have one patient that I'm currently doing something I said I would never do. I'm putting topical estrogen on the breasts. And which is like, and the reason I'm doing it is that they have failed transdermal, injectable, oral. I've had their dose, their estradiol level at like 900, where they're living at near like what would be considered crazy dose, and still no breast development. So I said, okay, well, and they said, I'm going to go get breast augmentation surgery. And I said, okay, I'd rather you not, because I always think of Kanye West's mom, who went in for routine breast augmentation and died. It's not without complications or surgical problems or capsular contracture or other issues. So let's try one more thing. I can screen for breast cancer, but I don't have a crystal ball to say whether my patient reacts to anesthesia and dies under the knife. So that's what we're doing right now. And with that patient, I've had modest growth so far, but I think that they may be a person who is fused prematurely with spironolactone. So I get testosterone levels on people with the intent of erectile function. If you don't want it, and most of my transgender women do not, they say, no, make it go away. I don't want to get morning erections. I don't want anything. Like, they hate it. They call it the dysphoria worm. I mean, there's the, what is the other one that I always say? Oh, God, I'm trying to remember now. The sadness noodle. I mean, there's just like, there's so many funny things that my patients have said to me before that I like try to store in my head. But regardless, if they don't want it to function, I keep it about 15, which is the adrenal levels that are produced when you shut somebody down using the Powers method, which we're going to talk about. If they want it higher than that, I keep them around 50. Anecdotally, African-American trans women want erectile function. Whites don't. I don't know why that is. It's just a thing culturally that I have noted overwhelmingly to be true, and a fact of like 90-10. When it comes to white transgender women, they're usually like, meh, like they're either apathetic or they don't want it. Very rarely are like, it needs to keep working. Whereas with my African American trans women, almost every single one of them would like to preserve their erectile function. It's like critically important. I don't know if it's a cultural difference or what, but it's something that I'm aware of and I cater to by helping them do this depending on what testosterone I keep them pegged at. All right. So there are other blockers that I don't use because they're terrible. 5-alpha reductase inhibitors. So there's a brand new drug out right now that is injectable, and it treats postpartum depression. So women that are like severely depressed, right? The problem with this drug is it has to be infused, and it has to be infused slowly over a 48-hour period. So you have to be in the hospital with the severe depression, and then they hook you up to it and they infuse it into you. And it's allopregnenolone, which is a neurocorticosteroid that is involved in depression. We find that it is heavily depleted in women with postpartum depression. Giving it to them makes them feel better. Do you know what else depletes neuroallopregnenolone? 5-alpha reductase inhibitors. It blocks the synthesis of it. I wonder why there's such severe depression associated with the usage of finasteride. But yet we hand it out like candy. Just like, oh, you have some hair problems? Here, have some finasteride. Oh, you got prostate cancer? Finasteride. Meanwhile, these people are severely depressed because we're literally depleting a neurocorticoid, which is super important to their general functioning. I don't write these, like almost never. And when I do, I write them topically, and that's it. I have a compounded finasteride or dutasteride with minoxidil at 10% that I put on the head, but I won't use them orally on people because there's just no reason to do it. The other reason it's stupid is that the overwhelming majority of transgender women have a very low testosterone to begin with. 5-alpha reductase inhibitors don't block testosterone at all. All they do is prevent the conversion of testosterone to dihydrotestosterone, 3 times stronger testosterone. It's a more potent form. So if your total testosterone is 10, why do you have the patient on finasteride? You cannot imagine how often I have people come to me that have a testosterone of 0, 10, 15 that are on finasteride and this and that. And I'm like, what is your doctor doing? Because you just expose them to the side effects for no reason. So don't do that. Dutasteride can also be used topically, like I talked about. I have a compound that does that. Never prescribe any of these things to somebody who basically has a low T, because you're giving them side effects for no reason. So there was a drug called flutamide. There still is, actually, and it is an incredibly potent androgen receptor inhibitor. The best way to describe how it works, and I love this drug class, is here's a testosterone receptor. Spiro, all these other things block or reduce T levels, but flutamide, bicalutamide, and enzalutamide do this. They're like a bowl that sits over top of the receptor. They prevent the binding of the ligand. So it just sits here and inhibits the ability for testosterone to do anything. About 50 milligrams a day of bicalutamide is enough to inhibit about 400 nanograms per deciliter. So pretty solid amount of T you can just wipe out by using bicalutamide. Now, the reason I use bicalutamide instead of flutamide is that flutamide has a horrible reputation. It is like the angry, mean cousin of bicalutamide that causes liver failure. Bicalutamide causes hepatic irritation in about 1 in 500 people. I've seen it once, ever, and it was very mild. We're talking like their AST and ALT went to like 60 compared to the other things they're on. I generally also use bicalutamide for another really cool reason. If I took it, say I had prostate cancer and I take it, no estrogen, no nothing, just bicalutamide, I'll grow breasts. It causes gynecomastia. The reason it does this is that when you inhibit the binding of testosterone, the body recognizes that it's not getting sex hormone signaling, and so it upregulates the expression of the estrogen receptor on the cell surface membrane, thereby sensitizing the cell to estrogen. Why are we giving people a testosterone poison that literally causes visceral adiposity and makes them feel like crap when this exists? It's because people are afraid. They're afraid of this drug, but I'm not, and I write it constantly. You can get it for like $16 a month at Kroger with a GoodRx coupon. I only use this drug temporarily right at the start of hormone therapy until I'm able to achieve what I call capture. Capture is the point when I own your endocrine system. It does what I tell it. It basically has stopped doing what it wants to do on its own, and it does what I tell it to do. And I'll explain to you how I do that in a little bit. I have to edit the slide. I've never seen a hepatic transaminase elevation once. 2 weeks ago, I actually saw it for the first time. Like I said, AST and ALT went to 60. All right, so in not the United States, there is cyperterone. Megase exists here. We have megestrol. But cyperterone acetate, CPA, is a blocker that's used in Europe constantly. It's what everybody uses in Europe. It causes prolactinomas and meningiomas. I don't use it because I can't, but even if I could, I still wouldn't. But you need to be aware of it, because if somebody comes in having taken it and they have, their peripheral field loss or whatever, you need to be aware that literally this thing can cause a brain tumor. I once saw a patient abusing cimetidine. Apparently cimetidine can cause gynecomastia, probably via its P450 inhibition. It screws with the cytochrome P450 system a lot, and so subsequently people try and take it to get gynecomastia, along with a thing called Pueraria mirifica, which is a plant that's like one of the most powerful phytoestrogens you can get that isn't outright estrogen without a prescription. I have a lot of people who are ex-DIY, meaning they used to do this on their own from the street, ordering it from all-day chemists in India and getting it shipped to them, and now they've come legit. They come to see me because I offer the opportunity to informed consent. All right, progesterone. Everybody thinks I'm nuts, that progesterone doesn't do anything. They are wrong. It does. It wouldn't exist in the human body if it had no purpose. If you don't give your transgender women progesterone, they get pointy boobs. I literally jokingly refer to it as trans-cone boob syndrome. They are pointy. They literally look like Madonna. They don't turn out right. It's a cone on a cone, and it looks literally like the secondary nipple, the areola is enlarged, sitting on top of a strange cone-shaped breast, because they never progress past 10 or 4. They are stuck in 10 or 4, and unless you give them this, they will not make it to 5. I have not seen patients make it other than this with progesterone. However, if you look up any other resource, well, not any other resource, but most other resources will say that I am wrong. However, I also do not write this. Ever. Ever. The fact that Yaz and Yasmin are still in the market with drospinerone in them blows my mind. Why? You guys know Yaz, right? I mean, it's a birth control that's like the most sued and litigious birth control to ever exist. Drospinerone is 8 times more deadly than every other progestin out there, yet we still prescribe it to people. Why? There's no need. I don't have to do this because I have this. This is bioidentical progesterone. Now, what I do that's a little different, and it is basically the crux of the method for me, is that I use rectal. And you have to think about the level of compliance I have for my patients, that I convince them to use a rectal suppository every single night of their life. And they do it. The reason I do it is because when you take this orally, about 95% of it is obliterated in the liver. It just never makes it. And their serum levels suck. But when you use it rectally, you wet it in your mouth or into the sink, and whoop, up it goes, and you go to bed. The cool part is progesterone, when absorbed in this way, is a GABA agonist, so it makes people sleepy. So they sleep super well on it. They say it's the best sleep they've had in their whole life. Then, the other benefit is that the distal third of the rectum, unlike the entire rest of the gastrointestinal tract, drains to the portal circulation. I'm sorry, not to the portal circulation, to systemic circulation. Everything else goes to portal, meaning goes to the liver first, but the distal third goes out to systemic. So when you put this in the distal third of the rectum, the capsule will basically start to melt, break down, and then release. And because it's an oil, it doesn't get all sucked up instantaneously. Over the next 24 hours, it is gradually absorbed. Then what's really neat about it, I think I have to go to a further slide to get to it, but I'm just going to tell you now. I discovered based on lab results I had in a patient, and I tried to find a comparative example, and there's a 1998 study on sheep where they inject them with progesterone and they measure their LH and FSH and it goes to 0. So I said, I bet if I can get progesterone levels high enough, I can do a thing like Lupron. Because progesterone is actually a GnRH agonist. Now, if you don't remember how the hypothalamic pituitary axis works, GnRH agonists stimulate the pituitary continuously. As in, like basically they press the button and hold it down. And once you do this, you get a release of LH and FSH, and then it stops. In order for it to work normally, you have to press, 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 press in a pulsatile fashion. And that's how the pituitary regulates hormones. So if you give them progesterone in this way, which acts as a GnRH agonist and is a constant stimulus, LH and FSH fall to 0. When your pituitary is no longer secreting LH and FSH and they are 0, there is no signal to your testicles to make testosterone. They go off, just off. I never have a patient now that I have to give any other blockers to or do an orchiectomy on. In fact, what's really cool is their testosterone falls to usually about 10 to 20, which is the amount synthesized from the adrenal glands. I know that it is because their LH and FSH are undetectable, and their testicles are like totally atrophied away. So this is how it's working. That is the crux of how I do hormones differently, is this usage of rectal progesterone. I have also used topical progesterone on alternating breasts, and every now and again I have somebody, and even one cis woman I did it to, who had an asymmetrical breast, and I used it to enlarge the smaller breast and like even them out. And it actually worked, and they got gains, and they were very happy, and then we stopped the drug, and it kind of was like, and it went back. but not as bad as it was before it started. So the presence of the progesterone effectively evens them out because topically the concentration they're getting is vastly higher than the systemic absorption. I'm sure the other breast is touching some of that progesterone, but when it's right on top of the right side, it evened out the other breast, which was kind of neat. Her period was a mess though, but she didn't care because it was that or surgery. She was like, I'm getting this fixed. So it was one of those things, kind of like my other patient I talked about, where it's, a risk-benefit ratio, but rather than going under the knife, they opted to do that. WPATH, progestins, with the exception of cyproterone, the inclusion of progestins in feminizing hormone therapy is controversial. Back in 2000, you see all these citations are always going to be like 80s, 90s, because this is WPATH. Like they don't update their stuff. Because progestins play a role in mammary development on a cellular level, some clinicians believe these agents are necessary for a full breast development. However, clinical comparison of feminization regimens with and without progestins, mind you what this says here, progestins, not bioidentical progesterone. It says progestins. Found the addition of progestins neither enhanced breast growth nor lowered serum levels of free testosterone, which I just told you is absolutely not true and how it works. But that was 1986. There are concerns regarding potential adverse effects of progestins, including depression, weight gain, and lipid changes. Depression and weight gain I have absolutely seen, and I've had to stop it on people for that reason. It makes them hungry. And some people, while they get depression, other people, they feel much better on it. It just is the way that like an SSRI can make somebody better or worse. It just does a thing. But I would say the overwhelming majority of my patients tolerate it. I've seen people that got stuck at Tanner 4 go to Tanner 5. Support for natural progesterone. In clinical trials, randomized control trials evaluating micronized progesterone in Prometrian's product monograph, not one single case of thrombosis or altered coagulation factors is mentioned. Not even one. Bioidentical progesterone does not cause an increase in thrombosis. It also has a negative effect on cancer. It actually makes you less likely to get breast cancer. Only bioidentical progesterone does this. All of the other progestins have a net negative, every single one. But we don't use them. Instead, we're giving people Yaz for some reason. I don't know why. Anyways, continuing on. Oh, wait, here's some more. That isn't enough for you. No significant association of VTE with concomitant micronized progesterone, nor pregnane derivatives were significantly associated with an increased VTE risk, whereas micronized progesterone could be safe with respect to thrombotic risk. This is known. Like, this is the kind of stuff with medicine that just drives me nuts. Like, we know this stuff, but we keep giving people these things, like, even though this research is just totally out there in the open, like, but yet every day, here's your birth control with drospirenone in it. Have a good day. Hope you don't die. Like, all right. In people who've undergone full surgery, who have a successful androgen blockade, sometimes T will drop to 0. This is bad. You don't want to do this. The hippocampus requires testosterone. Cis women have testosterone. Like your memory gets impaired when your T falls to 0. So you do not want to block somebody all the way to 0. They have cognitive side effects from it. Don't do it. I will do this. As we talked about earlier, I use topical testosterone to the penis to restore the tissue and to grow it in trans kids that got blocked too early, effectively. Are you being safe? Obviously, you got to keep following these patients. I usually see them every 3 to 6 months. When they're early in transition, I see them like monthly, because I'm constantly running labs on them to adjust things and monitor to make sure that their lipids stay good, their liver enzymes are okay. It's a pretty regular change. I do this. PHQ 2 or 9, they get asked and they come in, they're basically like, are you feeling depressed? How are you doing okay? I don't always do the 9 at every visit. At every new patient, I run a full 9, but usually they ask people, are you feeling depressed? How are you doing, at very least when they get checked in to evaluate people for depression. Preventative medicine we're going to talk about. All right, so here we go, surgeries. So how am I doing for time here? Oh, geez. All right, metoidoplasty. So this is what we talked about earlier. You sever the clitoris, you bring it out. This is pretty much what you start with. You can see the enlarged clitoris from the testosterone exposure. Here it is being extracted. This is the urethra being mapped out because the urethra is then going to be used to fit into this graft, and here's the end stage penis. What you get is a penis that would fit perfectly fine on like a 10-year-old at best, but that's about as big as it gets. But you can feel it, and the sensation's normal. But the most important part of this is you can stand and pee. You can walk into a urinal and go and be a guy, and that's the most important thing to a lot of these patients. Phalloplasty, however, is the creation of a neophallus, an actual penis. This is not just done to trans people. It's also done to cis men who've lost their penis to war or cancer or God knows what. And here's how it's done. We basically usually take a graft of skin from the thigh or forearm, and you more or less wrap a tube in a tube and graft it on. And surgically it's shaped with certain interrupted sutures that create a corona and a glans and the whole thing. There are different ways of doing it. You can do a free flap phalloplasty, where you basically take something from the inside of the leg or elsewhere and you transfer the flap to be able to do it. You can use a pedicled flap. With a pedicled flap, you basically have the blood supply coming in instead of being removed, and you keep it attached in the way you're doing that. Radial forearm flap is more of a new way of doing it. You basically take the forearm, radial forearm area, along with the graft of the radial artery, so that you can basically preserve the blood supply to the tissue, and then they pull it across and they close the wound that they created to make the phalloplasty go through, effectively do the thing. After the penis has been made, like basically you wait like a year till the penis is like healed, as healed as could be, and then we do the erectile prosthesis and we put that in. These are relatively new. Free fibula flap, which is kind of neat. There's a dorsal, a latissimus dorsi or musculocutaneous latissimus dorsi flap. There's just other ways of doing this. You can take a skin graft from pretty much anywhere and make it into a penis, but these are the different ones that are done. This one, though, is cool, and it's brand new, and I think it's really, really neat. So basically, they take kind of in the same way that we do vein stripping, you take like the harvest from the saphenous. Well, they take a piece of flesh from down here that's innervated by a nerve, the sural nerve or lateral cutaneous nerve or any of these regions, and they make the penis with it. But what they do is they graft the nerve onto one of the branches of the dorsal clitoral nerve. If it takes, the dorsal clitoral nerve extends the sensation across the entire neophallus. So basically, it's as if the penis has the sensation of the clitoris, but distributed over the entire penis, which is, I don't know, but that seems to me like how a penis would feel for someone who just had a penis. The whole thing has sensation. But if it fails, you still have sensation at the base of the penis, because the clitoris is still buried there, so they still do get some erogenous sensation. This is the newest way of doing it that is really brand new. Here's an erectile prosthesis. It's kind of cool. Basically, in the ball on the right here, there is some fluid, and you squeeze it like a pump, and it goes up past the valve, and it fills up the penis, and you get an erection, and then when you're done, you squeeze a little relief valve, and the fluid goes back in. And basically, this is the mechanism for which we implant. There's usually a bladder in these things that's held up in the abdomen that holds additional fluid just so that they're able to get a full inflation. Penis transplant is a thing that has been done a couple of times on people who lost their penis in the war. They're all cis men. This will probably get done to trans men at some point, same as a uterine transplant to a transgender woman, which has now been done successfully in cis people, but it hasn't been done yet. But it's kind of neat. What's more neat than this, though, is that there's a new way of doing these things with these organs where basically you could take a penis and throw it in an acid bath. And what you pull out after it's been acided down is like kind of like a skeletal leaf, like you see in the fall, like that leaf that's like got the veins but all the internal structure's gone. They can use things like that to then create a scaffold which is non-immunogenic. That can be anybody's penis. They then take your stem cells, put it in the culture bath, and then your stem cells populate over the scaffold and make a penis. They've done this with a trachea and an ear and a couple other random things now, and they're looking to do it with the penis next. Top surgery is basically what we refer to as mastectomy. It's something that transgender men get. There's two ways of doing it. There's a double incision procedure where you incise underneath the breast, and this is for larger breasts, and you make these two undercuts, and this is this, effectively. And you will see these scars on trans men. They're pretty much a mark of the process. Or, if their breasts are small enough, you can use keyhole procedure, where you literally go into the areola and more or less rotor-rooter the inside out, remove everything, and then attach the areola back on. Best guy in the world at this is a guy named Daniel Medali in Cleveland. I have literally never seen anything less than an 8 or 9 out of 10. Like, every single one he does is perfect. Vaginoplasty, this is Sue Porn's work over here. This guy was the best vaginoplasty surgeon to ever live. He is retired now, or he's retiring, but he's in Thailand, and he is unbelievably good. Where, like, if you look at it, you're like, yeah, that's a vagina. Like, you'd have no idea. They're perfect. However, I have seen some serious hack jobs come out of some other places where I look at it and I'm like, I mean, that's a vagina. Where it's pretty bad, and the patients have to undergo a lot of revision surgeries to try and deal with the complications that come when it's done wrong. However, this patient, as you can see, comparatively, that's how much depth they have. They have effectively almost a normal vaginal depth there, and this is shortly after surgery. You can basically do a vaginoplasty a couple different ways. A penile inversion is the most common. They will do this by taking the penis, filleting it effectively, removing some of the internal structures, moving the glands back to be the neoclitoris, and then using the penile skin to make the vaginal canal. As I said before, it's important to have a big, healthy penis because it's what's going to be making a big, healthy vagina. If you don't have enough penile skin, you end up with a very shallow, small vagina that's painful and has other issues. And when there's not enough skin, or if a patient, so I have a patient right now, it's a very unfortunate situation, but this butcher, who I'm not going to name, but he's in Michigan, he's a urologist, when the patient was very mentally ill, went to him and said they wanted to have a penectomy done. Everything. This guy cut off everything. He took off the scrotum, took off the penis, everything, and left the patient with basically a urethral hole. That's it. So they came to me like, I'd like to transition now, but I have no tissue. And when I examined them, that's what I saw. There was literally nothing there. It was just a urethral hole and basically a tiny amount of scar tissue surrounding it. That patient is a candidate for this. A colovaginoplasty, where we use a segment of colon to create it, along with a free flap to be able to make the labia. Or a new type called a peritoneal pull-through technique, which is not really done all that much yet, but they use the peritoneum itself to create a vaginal canal. And the cool part about the peritoneal pull-through is it sweats. It effectively releases fluid like any other peritoneum does in the body, which moistens the vagina naturally and tends to have better internal cultures, meaning more lactobacilli, more normal vaginal flora. There's other surgeries, facial feminization surgery, which they basically undo what I have, which is Cro-Magnon face, where I've got the big Neanderthal orbital ridge and jowl and butt chin and everything else. They shave these things down and reshape the face to look more feminine. Voice feminization surgery is amazing. It used to be awful, and I would not have recommended it for anyone, because like a third of people lost their ability to speak. It was so bad. Now there's like 3 guys that do it, Dr. Kim in South Korea, Dr. Haben, and Dr. Siegel, I think is his name, in Boston. They all do this vocal feminization, minimally invasive surgery, where effectively they take a person like my voice and they go in and they cut off the vocal cord, its attachment, pull it up, tighten it, and the net effect of it is approximately this. When you pull the vocal cords tight, it increases the pitch. Now this makes me sound almost like kind of silly, but compared to my normal voice, it's a lot higher. When done properly, it is, look it up on YouTube. I did include the video in here, it's incredible. Yeson, Y-E-S-O-N Voice Center. There's a girl there named Jenny that uploaded her videos pre and post-op, and it's just incredible, incredible difference. Obviously, breast augmentation, tracheal shave, shaving down the Adam's apple, buttock augmentation. This is a problem. Oh my God, is this a problem? Again, kind of a thing that's more seen in the African American community than the Caucasian and Latina communities, but they take basically industrial grade silicone and inject it into their body. And I see some nasty infections and complications related to this. The slang term for it is a pumping party. They will go to like a hotel and someone will have this and they'll do these illicit injections. And obviously an orchiectomy, just removing the testicles. So should we do this? Is it a thing that we should do? Well, we did once back in the 1800s to this person. So Lily was a intersex woman living at this time who identified as female. And we put her on hormones, transitioned her, and then did a vaginoplasty and uterine transplant. In 1929, 1930? Yeah, that didn't go well. We didn't know about any rejection drugs at that time. She lived for like a month afterwards, rejected the organ, died of sepsis. So the concept here, though, is at this time period, there was people willing to provide these services to these people, but there was this level of demand that someone would go through this, even when we had very little experience doing it. So in short, these people are really desperate, and they will do some crazy things to themselves in order to get access to hormones. So just be aware of it if you see one of these patients at some point that they might have gone through a lot to even get to the point of being able to see a doctor. Also, in order to get the care that they want, they can probably have DIY'd or exposed themselves to some really dangerous things. I had a DIYer the other day that was taking their sister's birth control, which is ethinyl estradiol, which is not a very effective thing for transitioning, but we're taking mega doses of it, like 4, 5, 6 pills at a time. As her sister was just filling it, but not actually doing it. So they were basically getting their birth control for them. Super risky thing to do, but in short, desperation will make people do crazy things. Moral of the story, safety first. Don't do anything that's gonna hurt your patients. What bad things can happen? Well, I mean, cancer, heart attack, stroke, clots, liver failure, kidney failure, osteoporosis, seizures, regret, I guess in theory. But I mean, they happen to regular people too. And in my patients using bioidentical hormones, I don't see these happen like the levels where I should. What's really interesting is I actually see them happen at a lower level in my transgender people than I do in my cisgender patients, which is fascinating. But regardless, there is some risks, something you need to be aware of. How often does it go bad? 5 years and 1,500 patients. It's now 6 years since I made this lecture. Never had one adverse event, not even one. And I can stand here and say that because if I did, you know it would come back to haunt me. But I have not even one. I have 3 adverse events that are not major, and it's people who had the estrone ratio problem when I first discovered it and I fixed them. Their breast grew so fast in response to the changes that they got stretch marks. None of them were mad. None of them were mad at all, but they would get some axillary stretch marks because the skin could not keep up with the breast growth. So now when I make a switch like this in somebody, I monitor the breast for the next few months, and if they get kind of red and irritated, I back down their dosing to slow down the process to allow the skin time to grow to fill in that space. But I have literally had a patient go from like an A cup to a D cup in 12 months, and they got axillary striae as a result. So I'm very careful with that now. That's probably the worst thing that I've done to anybody in all these years. Is it worth it? Sometimes it's not. Some people have gender dysphoria, and it's like, meh, yeah, sometimes I wish I was a girl, but like, it's not enough that it's worth it. They don't need to. Not all transgender people take hormones. Someone can still be transgender and not take hormones. You don't have to transition to be transgender. The act of being transgender is having gender dysphoria, but not everybody is going to go through that process. You can also be intersex and trans, to be clear. You can be both. You do not, they're separate constructs. You can have Klinefelter syndrome and identify as transgender. That doesn't necessarily make you not trans to do that. However, some intersex people do not like to identify as transgender. They view themselves separately. Depends on the patient. Just ask them how they feel. All right, let's talk about the preventative medicine stuff and office policies. We're wrapping it up here, so we'll get to the end as fast as I can. These are the people who give decent guidelines. They're where I would go if you have no idea what you're doing and you want to start from scratch. That's what I did. I learned these, and then I kind of grew from there. Establishing a safe practice, obviously educate yourself on these sort of issues. You're doing that right now, thank you. Assess the office environment, be sensitive to your patient experiences, like my bathroom is unisex. I don't have a male and female bathroom, I have a gender neutral bathroom. Have relevant and appropriate health information, provide PrEP, which we're gonna talk about. Advertise yourself as LGBT friendly. It's a mark you can give yourself on Google. You can literally mark, boop, trans friendly space and LGBT friendly. That's a thing you can do as a business. Train all staff to use culturally appropriate language. My staff is really good about not misgendering people, and my EMR is designed specifically for that purpose. We have preferred names, and everything shows up. Even though I have their legal name, they're called by their preferred name every single time. At my office, actually, we do a really unique thing where when you check in, you don't give your name, you give your initials. Is the probability of somebody having like the same initials, like 1 in like 16,000 or something like that? It's very, very unlikely. So you give your initials, and you're given an amiibo. If you don't know what an amiibo is, it's like a little Nintendo figurine. It could be like Toad or Bowser or any of ththose things, and it's like, hi, you're Toad. Then your chart is appended with Toad, and then when it's your time to come back, they're not like, hey, Will Powers, you're here for your semen sample? Because that's actually what happened to me. I went to give a semen sample because me and my wife are planning on having children soon. There she is, hi. And I wanted to make sure everything was okay before we attempted that process. And so I went and I sat down in this room of fertility clinic with a bunch of women surrounding me, and they called out my name and said it was time for me to give my semen sample. And I was like, I am not going to do this when I have my own practice, and I don't. So you get called back as Toad or Bowser or whatever, and that's the name that's used to refer to you when not inside of an exam room. Safe zones, obviously, just make it seem like your practice is welcoming to these people, not excluding. Having written and posted policies, non-discrimination, things like that are great. Intake forms, okay. So I went viral recently, again, off the same post. It's been shared like 7,000 times and viewed by like 1 million people over this complaint I had about an intake form that basically said gender. And the patient was intersex. And it was male and female. And I was like, okay, not only should this say sex or sex assigned at birth, it says gender, and even that's still wrong because I can't assign this patient's non-binary and they're intersex. So I literally wrote it on the form, like, no, patient is gender variant, assigned female at birth, intersex, blah, 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 it went viral. You don't have to do that fanciness. I mean, literally, if you just leave it blank. So on my practice, the intake says sex, assigned at birth, gender. And then it's male, female, and then there's a checkbox with a blank next to it. Because if you're something else, you just describe it there, and that's it. All you have to do is leave a blank. When you leave a blank, you're basically letting these people know, hey, there's a space here for you. It's an open space where you can describe yourself. Do not give people checkboxes. It's so much easier to do a blank. There's the form. That's the one. This is a good form. Sex at birth. This is a chorus. This is a cardiac test that I order sometimes. And here they want to know what your sex at birth is because it stratifies your risk. They also should ask whether they're on hormones because, believe it or not, your cardiovascular risk is more associated with the hormones that you take than the sex you are at birth. This is how I can describe gender to people. All of you have this. You are all on this somewhere. You identify as male, female, or somewhere in between. As much as Tumblr would like to say that there are more than two genders, there's basically two. There's male and female. And then there is everything in between, as in male and female, people who that are non-binary that identify as sometimes male, sometimes female, gender fluid. And then there's neither. So when I describe like that water bottle, what gender is it? It's water, it doesn't have one, that's it. That's how some people feel. They don't really feel masculine or feminine, they just sort of feel in the middle. But there's not like these, they always attack the liberal media, by saying like, oh, 58 genders, Apache, I identify as Apache helicopter, like all this ridiculous stuff. It's really not the case. Human beings exist somewhere on the spectrum. You can express yourself as feminine, masculine, or something else in between. You are assigned at birth, female, male, or intersex. We went, smack it on the butt and look at it and be like, yup, that's a whatever. That's how it works. That doesn't necessarily mean you're karyotype. Like I said, I've already described you people who could be, you hold it up and be like, oh, penis, boy. And in reality, you're holding an XX fetus that has De La Chapelle syndrome. Physically attracted to, you can be pan, straight, gay, lesbian, bisexual, whatever you want. Attracted to men, women, people that are in between, other genders, people who are transgender. You could be attracted to everybody except for trans men, or everybody except for cis women. And there are different gender and sexual identities that correspond to these different things. Also, emotional attraction is not always sexual attraction. So some people find themselves like they'll be bisexual, but they really this is very common in our society. You see a lot more acceptance of bisexuality in females than you do in males. So subsequently, you see a lot of females who are married, have a boyfriend, whatever, and then hook up with a girl. And they're bisexual, but they say hetero-romantic. Whereas in the African American culture, there's something called the DL, or the down low, where it's very common to find young black men who have a girlfriend who then get HIV by engaging in MSM, and then they bring it home, which is why African American cisgender women is the largest rising group in terms of like proportion of HIV infections in the United States right now, is the DL culture. Insurance, you need to know the patient's current legal gender, and you need to know their current legal name, and that's what you use. That is what you should submit always. Don't submit anything else. If they change it, submit that. And sometimes they've legally changed their gender but haven't told their insurance yet, so don't do it then either. So you need to know what the situation is, and we basically are constantly monitoring that with my patients that are transgender. Insurance coding can be a real pain. I have a transgender man that I had this problem with. He was 30, and he has high-risk sexual behavior and really needed a PAP. He'd never had one his whole life. But transitioned 10 years ago, has a male name, male gender. His insurance doesn't even know he's trans because he got this job recently and has completely legally changed everything. And getting a pap smear on him was a real pain with the insurance because they're like, not approved in men. I'm like, nope. Patient has cervix, and they've rejected it again. And so I basically had to get somebody on the phone and be like, listen, idiots, this person still has a cervix and needs to be papped. Fluidity, some people identify as different genders at different times in their life. It changes for them over time. It's a thing that they can be exposed to, which can make them discover a new thing about themselves. Some people just feel more masculine or more feminine on one day. It is very common in the youngest culture right now, like millennials and people younger than them, to express gender fluidity as it becomes more accepted in culture. Transgender etiquette, call a person by their name. It's not hard. I told you my name's Will. Call me Will. I didn't tell you what pronouns I prefer. If you don't know, you can more or less look at me, and if my name's Will, probably assume that I use male pronouns. If you say, hey, Will, go hand that over there to him, and you point at me, and I go, actually, I prefer they, them pronouns. Be like, okay, go hand that to them. That's it. That's all you have to do. You made a mistake, patient corrects you. Sorry, I didn't know, or sorry, I didn't mean to say that. Correct yourself, flame on. You're not going to be the first person to misgender a transgender patient. That's like what happens to them literally all day through transition for years. Just don't be a jerk about it. When you screw up, be like, sorry, I'll do better, and then flame on. I have, since opening my new clinic, seen 500 novel patients and approximately 1,000 visits, and I have misgendered 2 people. Twice I have done it, and I almost never do it. And in both situations, I did it because their spouse did it. And I mimic the spouse, which is what I have trained my brain to do, is if the spouse uses a particular pronoun, I use that pronoun. because I made the assumption that that's what they would prefer. Oops, I was very wrong when I did that, and I had to correct myself. I went, sorry, I didn't mean to do that. I just was mimicking your spouse. Odds are you're not the first person to misgender them. Respectfully ask someone how they'd like to be addressed. Ask appropriate questions. If you don't know, like you look at somebody and you're like that Saturday Night Live skit, it's Pat. You ever seen that? Okay, like what's Pat's gender? Like nobody ever really knows. The solution to that entire skit would be like, hey Pat, how do you want us to address you? What pronouns do you prefer? And if the person is not transgender, they'll be like, what? Huh? And if they are any sort of gender anything variant, they'll be like, oh, I prefer this. And that's the end of the discussion. Be like, oh, never mind, sorry, I was confused. I just wanted to say, I wanted to address you respectfully. That's it. Just ask. Literally no one's going to be mad about it. And if they are, they're the jerk, not you. Because you're literally making an effort to be civil to somebody. This is a thing. This is probably one of the more important slides in the entire thing. If somebody comes in with a broken arm to the ER and they're transgender, it's of course because they're on Spira or hormones. It's the hormones that made their bones weak. Everything. My patients come to me with literally everything. Because the really funny thing about transgender people, a lot of people that are in the medical field don't realize, is that transgender people are people. They're people. And people get sick. And things happen to them totally unrelated to that fact. So I have green eyes, and I have shit vision. It's terrible. We're talking like 7 diopters negative. That has nothing to do with the fact that my eyes are green. I just have terrible astigmatism. So I wear contacts that are like as thick of a dime, because otherwise my glasses would look like Coke bottles up here. That has nothing to do with me being green-eyed, and most of the time when a transgender person presents to your clinic with an earache or whatever, it has nothing to do with their hormones. Please do not make this assumption. It is very difficult for them to get medical care when everybody always just looks at them and says, yep, it's because of this, because doctors don't understand what taking testosterone does to someone assigned female at birth. So if they have an abdominal pain, oh, well, that's one of my favorite ones. If you're a transgender man and you go to the ER with abdominal pain, it's the only thing worse than a 20 to 30-year-old cisgender female going to the ER with abdominal pain is a transgender man doing it. Because they immediately assume that it's related to testosterone and you get the worst workup ever. It just doesn't, and I have had to deal with this where they've been like severely constipated, and if anybody just shot an x-ray, you would have seen the obvious constipation on x-ray, but of course it's their ovaries causing them pain because of the testosterone. They don't even ovulate. When you're on T for more than like 2 or 3 months at a therapeutic dose, ovulation stops. Like you don't have a period, it's just over, 0. Anyways, etiquette. Trans men will need a PAP every 3 years as per ACOG guidelines if they're in that group. If they've not had top surgery, they need mammograms. Trans women need a PSA if they complain of nocturia, strong family history of prostate cancer over age 45. Be an awesome ally provider. Remember these things I talked about. Do your homework. Don't forget your Hippocratic oath. You say you're going to take care of everybody no matter what. I cite the example that I have. This is really kind of interesting, but I have 5 pedophiles as patients. One of which, and what's really interesting, is of the 5 of them, 4 of them are women, and the one that just got out of prison for molesting kids came to me and said, I heard you'll take care of anybody. I said, yep, I will. He said, well, I just got out of prison for child molestation. I've been in for 3 years, and I want to never do that again. Please help me. And so what I ended up doing is I gave them a high dose of Paxil, which more or less shut down their libido completely, because they had gone to therapy and everything else. They still had this drive in their head they couldn't erase. And so they came to me for help. There is literally no reason to not take care of these people. They need help. It doesn't matter whether you don't agree with it or whether you don't. I mean, obviously I don't agree with what this person did. Clearly, that's why they were in prison. But I would gladly help society and them by preventing that from happening again. That can be extrapolated to pretty much anybody. I have bodybuilders that come to me that have been juicing themselves for years, that are like, I'd like to get off the testosterone. I want to have kids with my wife. And like they walk in like their neck is directly attached to their shoulder. And I'm like, okay. And I'm like, when was the last time you used Tren or Anavar or Danvar, any of the other anabolic like horse steroids? And they'd be like, well, last week and blah, blah. I'm like, cool, here's your Clomid. And I write them clomiphene, just like I do for my transgender women, to restore their testicular function. And sometimes they come back and tell me they use Tren again. And I write them clomiphene again. I'll never write them Tren. I'm never going to help someone hurt themselves, but I will help mitigate the harm that you did to yourself, even if it was stupid. Be an awesome ally and provider. So how many of you, show of hands, made a mental note of the fact that I'm wearing a pink shirt? You're busted! See, I do this every time I give this lecture. I wear a pink shirt. The The reason is because you have certain gender norms in your head that you associate with things. Blue for boys, pink for girls. So many people, like half of you, had like actual like, I wonder why he's wearing a pink shirt. Right? Yeah, exactly. How many of you assume that I am a cisgender heterosexual man? Probably the overwhelming majority of you did, because my wife's literally right there. But it might not be. I could be bisexual, pansexual. I could have been a trans man. I actually had a really interesting case yesterday where I had a guy who, the intake form from my office lists, you have a partner, are you married? Yes. What sex was your spouse assigned at birth? And they wrote female. So I read that, I was like, okay, blah, blah, and I sat down with this guy who identifies as bisexual, and he's going on PrEP, so like, they're non-monogamous, they're polyamorous, and they have sex with other people. And I was like, cool, okay, well, here's the situation, blah, 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 and I said, and your wife, is your wife active with men, women, or both? He's like, well, my husband, actually. And I was like, what? You marked female in front? Like, yeah, he's a trans man. I was like, oh, okay. And I actually got burned on my own form because I literally didn't have a way of describing, and I will now, the sex assigned at birth and then the gender of your partner, because it matters. Because in that regard, I have to think about, does the person they have sex with have a penis or a vagina? Do they need certain vaccinations? This is pretty dry, and I'm going to breeze through most of it because I'm going to tell you right now the answer to nearly every preventative medicine thing you can think of is screen perinatal sex. If you have the parts, you do the thing you're supposed to do for those parts. If you have breasts, you need mammograms. If you have a prostate, you need PSAs. That's how this works. This is all available, and there's on the back of, in the back desk back there, there's my cards, and there's a PowerPoint presentation that's linked from my website, and also the Dr. Will Powers Facebook page, which you can download this whenever you want. So I'm going to tear through it really fast because I'm running out of time, and I want to make sure that you guys don't get held too late. Current past hormone use, if you have a neovagina that is made of anything but colon, you do not need to pap it. It's stratified squamous epithelium. If you have a colonic vagina from a coloplasty, you need to pap it because it's columnar epithelium and it gets cancer. If you have the organ, screen perinatal female rules for cervical cancer, breast cancer, or uterine cancer. If you have it, you do what you would do anyways. For cardiovascular disease, screen perinatal sex. Consider that hormones might increase lipids, screen lipids. There's really not a whole lot of other things you need to do. Cardiovascular disease, again, pretty much same thing, taking estrogen, respect to lipids. Transgender people who have not used cross-sex hormones require the same screening criteria as persons of their natal sex. If you identify as transgender, but you have done nothing about it, you haven't taken anything, you just get screened as to what you were assigned at birth. Being transgender is not a license to not eat well. I often see my transgender women not exercising because they don't want to get buff, because they view that as a masculine trait. I see my transgender men gaining weight so they can be more blocky to try and hide some of their breast tissue. Effectively, they have a belly, like they flatten themselves down with a binder. Clothing, you need to know that this thing exists. It's called an STP, or a stand to pee. Free Tom makes the most of them. There's a number of different things. If your patient uses this, they need to clean it every day or they get some really, really nasty UTIs. They basically suction cup it or glue it onto the front of the vagina, and then they can stand and urinate through it. As you can see, this is the same human wearing bras and wearing binders. These things can be really tight. I do what's called the Powers four-finger test. Well, at least I call it that. Someday someone else besides me will call it that. But basically I take 4 fingers and I go like this and I put it on the side of the patient. So you don't do it in the front where it's all dysphoric and weird. You go over here where there's actually the greatest amount of impulse tightness from the binder, which is squeezing their chest to flatten them down. And if it causes them, like if when you put your fingers in there, they collapse onto each other. You cannot keep them in a row. It's too tight. Because effectively that's enough force to squish the rib cage down, which does cause considerable problems over time. And I've seen the saddest part is that they end up getting top surgery eventually, and then they have what I call reverse muffin top. So because they have literally squeezed their chest for so many years, all of their organs get forced down into the abdomen below the height of where the ribs are. So they kind of bloop out this way, and then their top is completely flat and masculine looking after mastectomy. So they look ridiculous, and it's because of many years of doing this. Make sure you monitor this in your patients. You'll see forms in patients early in transition that have no breasts that want to. They will use these. Sometimes they'll wear a thing that's I have one patient that wears things that are the size of beach balls. And I'm like, are you serious? And they're heavy. They must weigh 40 pounds. And I can see back pain associated with them. Because if you haven't had these on your chest for years, and they're only on some of the time, your musculature is not designed for this, center of gravity being moved forward, and they get back issues. Mental health, being transgender is not a mental illness, but transgender people have mental illness more than general population. Screen them, be more attentive to it. Musculoskeletal health, pretty much the same. If you have estrogen, you need D and calcium. Transgender women get osteoporosis. They get it more when you do a crappy job of prescribing them hormones and they don't have a high enough dose. I see it a lot, and people have been on like a pittance of oral estrogen for a long time. You can do same pulmonary screening, basically, in the same as you would. Getting people to quit smoking, telling them that like HRT is really risky used with smoking, which it is a great way to get somebody to quit. Motivates them like, oh, if I quit smoking, I can go on HRT. And I do that, same with HIV. Come on in for your HIV treatment. While you're here, I'll treat you for hormones. And I literally get them to come for that reason every 3 months, because they're really coming for their hormones. That's why they're showing up. But I'm treating their HIV while I'm at it. And I'm effectively, when their viral load goes to 0, I remove them as a node from the community. When the World Health Organization says if your viral load is undetectable, you cannot transmit the virus, period, unprotected or not. So these people that I have properly treated are no longer nodes in the community infecting other people. Don't assume the sexual orientation of transgender patients. Also, it changes, like a lot. My very first transgender patient was a young trans man who I started on testosterone, who identified as a lesbian, came out as a trans man, and now is a gay trans man. They're gay and they stay gay. Anecdotally, if you come to me as a female to male and you show up like, my name is Helga, I'm here to transition, like they're already heavily masculinized, facial hair, they don't change. They generally stay the same. But the ones that are like 5 foot to 5'3", pixie, like 110 pounds soaking wet human with very feminine facial features, they're attracted only to women when they come in, and then they're attracted only to men a year later. I've seen it happen an astronomical amount. With transgender women, it's more of a slow, gradual shift. If they're attracted to men at the start, they stay that way, generally speaking. If they're attracted to women at the start, or the colloquial term is transbian, a transgender woman, lesbian. They're attracted to women only at the start. They tend to shift a little bit towards bisexuality over time, a variable amount with estrogen exposure. Depends on the human. But it's something you need to be aware of, because if somebody's previously been attracted only to women and you're not screening them or vaccinating them for Hep B according to CDC guidelines, and their behaviors change from hormones, you need to know about that. So I usually ask my patients their sexual orientation at least once a year, if not more often. Providers for care for transgender people should enhance their HIV expertise for reasons I already said. Use a gloved finger, appropriate speculum. Be nice when you're doing exams of people. Don't do unnecessary genital exams. Don't ask a transgender person whether or not they've had the surgery, unless you need to know because they have a gynecological complaint. Like, unless it's relevant to your care for them, you don't need to ask them things. If a transgender person comes in and sees you in the ER for acute otitis media, it doesn't matter that they're transgender. You would not be like, oh, so I noticed that you're black. Or, oh, so I hear you have an accent. You must be British. Like, and it's not things that you would just bring up to people. Like, you wouldn't start talking to them about, oh, what's it like being British? Well, you would be taking care of your patient. So when you start asking them these questions about transgender things, it can be very insulting and demeaning to somebody because they feel like they're only viewed in that lens. So if I were trans, I would be like, Will the trans guy. Instead of Will the doctor who loves cats and is into Bitcoin and video games and bicycling and blah, blah, who's also trans. People often get pigeonholed in that identity. Silicone injections, we already talked about. Pumping parties, this is a thing you just got to keep an eye out for, especially in the gluteal area and along the hips and saddlebag region. Substance use is considerably increased in the entire LGBT population, with transgender people actually not being the worst. Lesbians tend to be the worst for smoking, alcohol with gay men. Everybody has a distribution that they end up in, but transgender people are kind of in the middle when it comes to the LGBT community for substance abuse. It's still almost double, though, the straight population. Thyroid screening, same thing. Vaccinations, there are certain things you need to do based on who they have sex with. So what parts do you have and who do you have sex with? Treat them accordingly for that. Homelessness is incredibly high. The transgender discrimination survey reveals a 19% homeless rate. I'd say at least 10 to 20 of my patients currently are homeless. I try and help them with that problem on a regular basis, but it's very difficult. HIV and AIDS, we already talked about. Transgender women of color have a HIV positivity rate of 56%, 57 actually as of this year. I should update the slide. It's pretty bad. So you should write them this. This is a drug that exists. I want to jump up and down so I can show how excited I am about it. You should write this drug. Anyone can write this drug in any specialty, anywhere. It's called Truvada, also known as PrEP. Soon it will be replaced by a newer form called Descovy, but the short and narrow is that this drug, when taken every single day as prescribed, makes you pretty much immune to HIV. it protects you against nothing else. And I see a ton of other STD infections in the people on this drug because they feel like it's like a license to go out and do whatever the hell they want unprotected. So I'm constantly seeing syphilis and gonorrhea and really weird infections in these people. I saw cancroid a couple of years ago. Totally serious. But it is so effective that in like 500,000 people who have taken it, there's been 2 infections. 2. And of those 2, both of them had, when they tested their hair, had serum levels under what would be considered therapeutic. They were only taking it a couple times a week. So like there has never been a documented case somebody taking the drug right with proper serum levels that popped up positive from it. It is that effective. And you can get it for free, and Gilead has all these things you can do to help them get it for free, and most insurances will pay for it, so just write it. You need an HIV test on them before, because if you give them this drug, and they're already HIV positive, you screw up nucleosides. You literally wreck the whole class, so don't do that. But if they're HIV negative, within a week of the time you're going to write them the drug, you write it for them. Every 3 months, you check them again, you monitor their liver and kidney enzymes, make sure everything's okay. For those who prescribe HRT, we're getting to the real end now. We got 3 slides left. Do or do not, there is no try. If you're going to do this for somebody and prescribe them HRT, you do it or you don't. Please stop being the doctors that are sending me these people who've been on a pittance of estrogen and a tiny dose of Spiro for years. Even if you're going to do the WPATH method, at least do it right. Where they're like afraid, like, here's 2 milligrams of estrogen a day and 25 of Spiro, and the patients don't know. They think that'll work. So they spend 5 to 10 years of their life like languishing away in transgender hell, stuck in between 2 genders in society where they don't fit in and they feel totally out of place. Don't do this. Either do it or don't, or send them to me. I welcome the competitors. I'm overwhelmed. I literally can't see them at the rate that they're coming in right now. We had 23 new patient calls today. I'm going to have to stop soon and say I'm full. That's it. And I opened 3 months ago. That's how let me make that clear. I opened on February 25th, and I've seen over 500 novel humans since that time. That's the rate at which people are flowing into my practice. So I welcome other people to do this. Make good use of the time you get. So I almost died a little while ago, and I'll talk about it, but yeah, this is how long you have left to live. Just so you know. Something you should be aware of. Make sure you spend your time right. You're doing things that you find rewarding. But this applies to transgender people because a lot of them feel like they didn't get to actually live their lives until they're finally out. So be aware of this. This is literally how long you have left to live. And if you're over 75, well then, good for you. About me, I went to Pitt, studied neuroscience, chemistry. I studied Universidad de Carlos III de Madrid. Si quieres, hablamos en español. I'm fluent in Spanish. I lived in Madrid for a while. I went to LECOM. I did my residency downtown at Wayne County Health Authority, and then I'm boarded in family medicine. I specialize in LGBT care. I have a cool office in Farmington Hills called Powers Family Medicine. This is the brother of the world record cat, Phoenix. There is an arcade machine I have in my lobby. My office is super chill. I'm going to talk to you about this really quick, and then I'm going to be done. So on November 12th, 2017, I woke up. My wife was at work rounding in the hospital, and my house was on fire. And I tried to put it out, and I couldn't. So what I did is I grabbed the fire mask that I had prepared for this eventuality, and I ran around searching the upstairs as long as I could for my cats. 2 weeks before the fire, they had been announced the Guinness World Record holders, and we've been on Good Morning America, like TV shows, and well, not physically on that one, but we were on Pickler and Ben and like Channel 4 and all this other stuff, like flying around the country with them, appearing on TV shows. So I hunted for them as long as I could until the fire mask actually separated out, and I breathed in a whole bunch of smoke, and I collapsed and I passed out, and I almost died. I got pretty mangled, windows blew out, glass cuts all over the face. I didn't work for over a year. And all of this was because I didn't have enough fire extinguishers. Maybe I could have fought it if I had more, I don't know, but we weren't prepared enough. We had just recently moved into this house. We just got married, and so we weren't ready. And what it was a massage chair that my old boss gave me. He didn't want it at the office anymore. I'd been there for years. We took it home. I loved it. It was great. I had it in the living room. It was plugged in but off, and it just decided to burst into flames. And when I woke up, the seat of the chair had flames coming out of it this wide around that were like this high. And I couldn't put it out. I tried. In short, they all died. I almost died, and I lost everything I've ever owned in my entire life, aside from my cell phone and the clothes I had on at the time, because I'd used it to call 911. If you don't know, when you call 911, your phone locks out. So the cats had trackers on their necks, tile trackers that I used to page them to find where they are. And when I attempted to do that, I couldn't open the app because I was in 911 mode and my phone was locked out. So just if you ever call 911, be aware that it is the only thing you can do with your phone while you are in 911 mode. That is a law. I didn't know that, but unfortunately it made it me unable to track them and set the alarms off because I would have heard them even in the smoke and been able to find the sound to get to them, but I couldn't do that. So in short, be prepared. This is the brother of Arcturus, the world's tallest cat. This is Phoenix Arcturus powers. So Arcturus is Arcturus Aldebaran powers. You can Google them. There's a bazillion articles about this whole thing. Our family was famous and then infamous within a 1-month time frame. But Phoenix comes to the office on Mondays and Tuesdays and is the therapy cat there. And on Wednesdays, Thursdays, and Fridays, Polaris goes, who is the Bengal cat. And they were in the pictures earlier. They're also in the pamphlets back. You can see the smaller Bengal cat. And he's a Savannah. So he's an African serval hybrid. If you ever want to get the latest version of this lecture, you can do it here. I always publish it here, and there's a link to it on powersfamilymedicine.com. That's it. Any questions? You can, and to be clear, I treat transgender people. I treat HIV. I treat the polyamorous community. I treat the BDSM community, specifically the Detroit House of Pain. I'm probably their primary provider because these people come to me and they get hurt doing stuff. You can ask me literally anything, and I will not be fazed by it. I assure you. I've heard more interesting questions than anything you could possibly dream up. So knock yourselves out.
I was just wondering, how many pediatrics?
So I see about maybe 2 to 3 a week. I have probably, a lot of them have aged out. I have like 100 that I've seen. I probably have like 50 right now. A lot of them are now 18, 19. They've aged out during the time that I've been seeing them. I don't start, like I said, young kids on hormones. There's such a media, like, that we're say, chopping off the penises of young boys who identify as transgender. It's not true. We're not doing it. We don't do surgery on anybody till they're 18. Jazz is a very rare case. They did it on her at 17 and a half. But we don't do that. There's no need to do that. You just block the kid. I mean, you could do this in any family practice, internal medicine, like anywhere. You don't have to be I'm not an endocrinologist. I do endocrinology all day long, but I'm a family practice doctor. Sometimes I treat sinus infections and other crap that happen to these same people, but you can do whatever you want to do with your own practice. But yeah, I see kids, but I primarily block them. When they hit pubertal age, then we start the process of doing hormones, assuming they have gone through sufficient psychiatric and gender clearance at that point. I will not allow kids to do informed consent. So, because, I mean, you're a kid. You can't give informed consent. That's the nature of being a minor. Even if the parent says it's okay, they still have to go to psych. Nothing? After all that? Really?
How do you convince your male to female trans patients to use the topical testosterone on their penises, soon to be neovaginas, when I'm sure the last thing that they want is to grow their penis?
Yeah, I'm going to. So how do I convince my transgender women to put topical testosterone on the penis when that is literally the opposite of what they would normally want to do? It was not something I could have done 3 or 4 years ago. In this community, I have developed a reputation for being the guy. I get better results than everyone else, my patients do better, and I have safer and novel ways of doing it. So when I asked people to start sticking progesterone capsules up their butt, a shocking number of them said it was okay, and they do it. So in that regard, I tell them, hey, this is going to be safe, and I monitor them too. It's not like I don't just give them the tea and then I don't monitor the level. I will draw a level on them a few weeks after they're on the therapy. I generally use 0.5%, which is like 1/3 of androgel, on the penis once a week, sometimes twice a week. And then I gradually, like till we get to the point where the tissue is like happy and functioning again. But I almost exclusively use it in people either having pain or difficulty. They want erectile function, they can't. I can always get anybody erectile function. Like I have a compounding pharmacy that makes me Quad Mix, which is an injectable that's a combination of different things that basically like you could stick it into a corpse and it would get an erection. I actually have a quadriplegic patient who's completely paralyzed and uses it, and it works. And him and his wife can have intercourse as a result. So there's always ways around it, so to speak, but with the topical testosterone, I tell them to do it and that it will be okay, and they believe me. And thus far, I haven't hurt anybody with it, nor regrown any beards, because it's a pretty wimpy testosterone, but it really does do the job.
questioning, but the only doctor she's seeing, I know the family for a long time, and she only seeing a psychiatrist after IO. This is great that you're doing this service. I have a daughter like you at Recom.
There you go. I have a lot to say about LECOM.
No, I'll tell you the story. My son he was dating this girl, like he wouldn't even go to, he wouldn't apply to DO school. But they've been married for 12 years and she's just amazing daughter-in-law I had, more than my own daughter.
Not bad.
It's a great school. I heard so many good things about Ecom.
Lawrence family got stuck with me. LECOM was a tremendous education. I have to say that they prepared me better for boards and other places than pretty much any other medical school out there with the things that they did. However, they are a totalitarian dictatorship, and it is a miserable place to go to medical school. It was a we often, me and my wife joke, and we sing that song, is it Rihanna, that we found love in a hopeless place? Yeah. So, yeah, we met over a dead body. But yeah, LECOM was brutal, don't get me wrong. But they do a tremendous job of educating their students. I cannot fault them for the education I got. It wasn't any fun, but it was a great education. Yeah.
Could you speak a little more on just the process of going against the norm and experimenting with these things? I mean, that sounds like it's been really positive.
Yeah. So the patient, oh my God, I want to say patient. The person asked me what it's like to go against the norm and the kind of process and how that feels to do that. And admittedly, it was not a thing that happened overnight. It's sort of a gradual process, like the frog in the boiling water. I started to notice things that I was like, huh, this worked better than that. And then I spent a lot of time online. I'm very active on Reddit, much to the chagrin of my wife. But basically, I spent a lot of time talking on transgender forums to transgender people. And a lot of them are DIYers in other parts of the world. And they gave me their labs and results and other stuff and information that was basically me. I call it my anecdata, because it's like an unofficial study, but I aggregated a tremendous amount of anecdata and started to realize that things didn't have to be the way that they were. And then over the span of many years, like I discovered the estrone thing first. But when I discovered the estrone thing, I was still writing Spiro. Then I started to switch to the bicalutamide. Then I started to realize I could use progesterone as a blocker. Like each thing was incremental. So it wasn't like one day I woke up and said, I've invented the Powers method. It really was just a gradual way of doing it over time. But I should have published it already. I was about to publish it right before the fire. But it was destroyed. All my research was destroyed in the fire. And to be totally honest, I was very mentally ill for a long time after the fire, and I was terminated from my job. They knew that, and I didn't look like I was coming back, basically, and so they terminated me, and I therefore lost access to all those patient records and all the research material I had on my laptop at work. I never got it back. So I've had to completely start over from scratch, and so I'm hoping by the end of summer to get the very first publication, the estrone one, done and out there. And then once like right now, I'm the guy in Michigan. That's how a lot of these doctors refer to me, is I have people from all over the world send me messages. Sometimes doctors are like, oh, I tried what you did, it's incredible, it's so much better, thank you so much. And then I have people that are like the head of endocrinology at the main gender clinic for the NHS in England, is basically of the opinion that I'm a complete idiot. And that's okay. I'm totally fine with that. That's also what they told the guy who discovered Helicobacter pylori. They told him he was a total idiot and he was wrong. And then he drank the dish himself. And then he got a Nobel Prize. So like, depends, but he was laughed at. He was literally laughed at. And so these people, they can feel whatever they want to feel about what I do, but yet I have a lot of satisfied customers. I haven't hurt anybody. I've had 0 complications. And if you look at my face, I'm the highest ranked family doctor in the state of Michigan. I have basically over 140 reviews now, and they are all 5-star, except for one single 1-star review from an anti-vax mom who's mad that I wouldn't see their trans kid because they think that the kid is trans because of vaccines. And yeah, I know. I know. What are you going to do? But the worst part is that I treat AIDS patients. I have actual people with AIDS that sit in my lobby, like legitimate AIDS, like on azithromycin, on drugs, Bactrim, to prevent them from dying of AIDS. I can't have your measles kid next. Oh, I had an actual measles case. I'm one of the doctors that had one. One of my patients, I can't tell you, I was about to tell you information about them and I can't. One of my patients, who may or may not fall into this group, was exposed to one of the Jewish kids at one of those centers downtown, and then developed 105 fever and a rash and the whole thing, and didn't go to the hospital for like 2 days. They were like, I'll get better. So they finally came in. We were like, oh my God, this is measles. So we sent them to the hospital, and they tested positive for measles, which is nuts. And long story short, we had to like call like every single person in the clinic at that time period and make sure that they had all been vaccinated and get a booster. Is anyone within a 2-hour time frame of their exposure? It's like there was this whole protocol I had to follow. But yeah, so that happened too. So I guess, you know, you go against the grain, you're going to have to deal with some of that sort of stuff. But I'm patient. It's going to be a war of attrition. Because what's happening is that the people are seeing my methods. This PowerPoint has been downloaded like 250,000 times. It went viral. So I made this after the fire. Full disclosure, I was very mentally ill, and I wasn't sure how much longer I was going to be around. And I had lost everything. And so I had put all this time and effort into this research, and I never got to publish it. And I couldn't do it officially then. I wasn't even working or anything. I had access to no patient data. I had nothing that I could write it with. So I basically made this, and I released it online so that in the event I died, it would be available to the public, so that eventually other people would discover it. Because I'd like to think that someone else would come to this conclusion on their own, but yet estrone and all these other things have been known since like the late 90s, and yet no one has done this yet. So I would say that no matter who you are or whatever field of medicine you're in, don't discount yourself and your own intuition and clinical experience, because you can absolutely advance medicine and make discoveries and things that I never would have imagined that I could have done just by sheer luck, my own stupidity. One thing I discovered by accidentally clicking the wrong lab, and I got a result back that was like astronomical, and I'm like, oh my God, oh, I didn't order that. Oh, I did order that. But then I studied it and figured out why it happened. So I mean, that's the concept, I guess. It's sort of a vague answer to your overall question, but anybody else? Yeah?
In your FTM patients with your androgen protocol, do you see increased aggressiveness?
Oh, hell yeah. I mean, that's just being a man. So we know that transgender men, so repeat the question. Do I see increased aggression in my FTM patients on testosterone? Transgender men commit crimes pretty much on parity with cis men. I mean, if that's an argument for testosterone, there, you know, that like, so to speak, men are wired differently. I've ever heard one, but I constantly have them come in and be like, I'm so angry all the time, and I'm so horny and hungry and rah. And that's just the nature of T. Like I've had transgender men come and crying apologize to me for what society does to men. I know, Me Too movement right now, right? Like imagine that, like they literally, this has happened to me like no less than 10 times. Apology, Dr. Powers, I'm so sorry. Now that I know what it's like to have lived life as both a woman and a man, it's just so wrong what society does to men and how they treat us and I'm like, tell me more about that. But in reality, it is absolutely a thing. They see increased sex drive, increased aggression. They commit crimes, like I said, equal to that of cis men. It's a thing you have to watch for, and it's actually something I warn them for. Particularly, I have problems where when the sexual orientation flips and they're already in a long-term relationship, cause a lot of relationship discord. And when you have that like, me club, me angry is like in your brain, like that id, that intrinsic like way of functioning, and you have not been raised to be a gentleman. Girls are not raised in society not to hit their brother. They just hit the guy. Like that's why we see women slap men, but you don't see men like deck women in society on the regular. It's just not an acceptable cultural thing. Girls can hit a boy, but guys can't hit a girl. Well, if you've been raised that you basically are not held to that standard your whole life, and then now you're filled with rage and testosterone, you don't have the societal conditioning to behave as a gentleman. And I have absolutely see them commit crimes, get in trouble with the law, relationship violence, yes. To answer your question, yes. You have to monitor for it. And you back down their T-dose if it happens. Some people, I generally let my trans men run between about 700 and 900, which is effectively where I was at peak physical fitness when I rode for Pitt's crew team back in the day. I was carved out of marble, and that's what my testosterone was. I had like 900. And so I'm like, that's what would be normal for a young, healthy man. As they get a little older, I let them run a little lower, back kind of following what would be like, 500, 600 range, down to 400, especially if they've fully masculinized, like they're totally maxed out. There really isn't any need to keep them running that high, or I say running that hot, almost like you're revving the engine. But effectively, yeah, I mean, it's a thing you have to monitor and adjust accordingly based on the patient's behaviors and reported issues.
I know you mentioned you're the guy for Michigan, so I imagine there's not a lot of people
Do you at least
There are 0.
have an association like nationwide of the community to do it, or you guys?
Nope. So, yeah, that's pretty much it. So to repeat the question, do we have an association? Do we work together, me and the other providers? I know all of them. I can tell you them right now. Like, it's Patricia Smith, Alza Hiley, U of M's Gender Services Center, Bishop, Randolph. I think of who else off the top of my head does it. Uncle Diddles used to do it. Sikorsky, who's a doctor that's been on trial a lot for various reasons. But he doesn't have a DEA anymore, so he doesn't write testosterone, so I just absorbed hundreds of his patients. It just came over to me. But yeah, so they're all doing their own thing. They're all following the WPATH method, more or less. A couple people do some slight variances. U of M doesn't prescribe progesterone, period. Just no. The answer is no. You get Spiro and estrogen. That's it. That's what you get at U of M. That's their rule. That's how they do it. And so yet while we kind of punt patients around to each other as people get frustrated with one provider or another, I've tended to aggregate more than I've lost, apparently, because my methods are different and I'm willing to do things for people that other people aren't. But there is no major medical society besides the WPATH, which you can belong to, which I did belong to back in the day, and I didn't renew my membership because I don't agree with what they do. But at least, how often am I sitting in bed answering emails or being on Reddit? More than my wife would like, replying to doctors from all over the planet that send me random messages. Yeah, I mean, I'll respond to pretty much anybody. If you hit me up on the internet, you ask me a question, I'll give you advice. I won't tell you like what you should personally do. I'll never give personal medical advice to somebody I haven't examined. But like, for a similar patient, yes, your estrone of 4,000 and your estradiol of 200 is a problem. I would have corrected this in my clinic, because a lot of patients are finding out about my theories and then getting their own labs run at like any lab test now. You can go to like websites and order these labs, and they're like being told by U of M that what they're doing is fine. They then go to the lab, they find out their estrone is astronomical, and then they come to me and they're like, so that happens a lot, and whether they're from U of M or from UCSF or Washington or Texas. I have patients that fly in from like everywhere. So far, we've seen people from Alaska, Hawaii, Washington, California, Texas. We had a patient drive all day from Maine and then drive back the same day, which is pretty crazy. But at least once or twice a week, I have a patient that either flew in to see me or drove from an incredibly long distance. Sometimes a lot more than that. The first couple of weeks, it was nuts. It was like every other patient was from like a totally other state because they just can't find the care. Thus my point of like, if you guys are gonna do this, I literally feel like Field of Dreams. Like, if you build it, they will come. Like, I did not intend to do this. I just had 1 and then 2 and then 4, and then I became like the Holden Caulfield of the transgender population, like catching them in the rye, like as they come to me, because there's just so many of them. I can't catch them all. I can't. I need help. I do this to try and be like, hi, help me. There are too many. They need help. They need care. Some people are driving to me from astronomical distances. That's ridiculous. They should be able to go to their family doctor and get this done. It's not that complicated. It's really not. I don't know. Anybody else? Nothing juicy yet. Come on. All right, cool. Thanks.
Thank you very much, Dr.
I will hang around afterwards if anybody wants to ask me anything you didn't feel like asking in front of 30 other people.